A very good morning, everybody. I'm delighted to see so many registrations and so many people who have gathered here for the Diagnostics AI track. If you had spoken about AI digital pathology probably a decade ago, there would have been resistance from the pathology. And today we are embracing this technology with open arms. I welcome our chairman, Dr. B.S. Ajay Kumar, my senior colleagues from HCG and other institutes, as well as the speakers and all the delegates to this wonderful program here. AI has become an integral part of our day-to-day activities, whether it's a smartphone or visiting a bank or even the Digi Yatra app that we use in our airports. Healthcare is no different to it. And in fact, the highest experiments or applications of AI have been explored in healthcare, and particularly in pathology and radiology. AI is actually reshaping pathology by augmenting diagnostic accuracy, improving workflow efficiencies, and enabling data-driven insights from digital pathology. As whole slide images, computational pathology, and machine learnings become increasingly integrated into our clinical practice, pathologists are accepting transitioning from traditional microscopy to technology-assisted decision makings. Rather than replacing the pathologist, AI actually is a powerful tool that enables the pathologist, supports the pathologist in the practice of precision medicine, standardizes interpretations, and supports personalized patient care through integration of multi-omics data and enabling translational research. This conference is designed in such a way to shape the real-world practical applications of AI, machine learning algorithm models in our pathology laboratories, from diagnosis to interpretations to workflow efficiency improvements to research to bringing the knowledge of data science to the pathologists. It also addresses data management, storage options, and ethics. This conference brings together pathologists, researchers, data scientists, clinicians, and industry experts to explore latest advances, real-world applications, and future directions of AI in pathology. Through scientific discussions, case studies, collaborations, exchange of ideas, we aim to explore both opportunities and challenges of implementing AI, including the validation, the regulations, the ethics, data analysis, and clinical adoption. We have experts from pathology laboratories who have successfully implemented AI. We have industry experts and well-known data scientists, as well as researchers and scientists who are, including the policymakers, who are here with us today, who are going to share their experiences with artificial intelligence. I welcome each one of them and thank them for their active participation in spite of their busy schedules. Here is an opportunity for all of us to collaborate and learn, shape a future where AI and human expertise work together to improve diagnostics, excellence, and improve patient care. I once again welcome you all to this session on AI in pathology, and I'm sure that at the end of this session, we all will go back with a lot of learned material and also start exploring how do we apply that in our clinical practice. So let's begin with the first session. Thank you.
Welcome to all of you. Let me welcome Dr. Satish Vishwanath. So it's a real pleasure welcoming you here. He's a forefronter, a doyen in this field, and very appropriately begins the conference with his huge amount of experience in this area. Dr. Satish Vishwanath is an academic and researcher whose work spans, as we all know here, and all we have got together to understand, explore, churn, spans artificial intelligence, biomedical engineering, and translational oncology. As I was saying, who better than him starting this conference? His research focuses on developing AI-driven approaches for medical imaging, cancer diagnostics, and precision medicine, with a strong emphasis on bridging computational innovation and clinically relevant applications in oncology and translational research. Over to you, Satish. Well, we look forward to your talk. I think it's a 15-minute talk, is it? 15 minutes? It will be great if we can keep 2 minutes for questions, maybe 13 plus 2 or something like that. Thank you.
Sure. So thank you very much for that introduction. Um, Thank you to the organizers and the HAI conference for giving this opportunity to talk to all of you today. I'm very happy to be part of this opening session. So we're here to talk about hidden signatures, multimodal imaging, digital pathology, and a few other aspects around multimodal AI as well. So just to kick things off, we're here to talk about healthcare, widely known as the next frontier for AI potentially. And I really like this particular graph because you can kind of see the evolution of AI in healthcare. So these are the number of publications every year going all the way back about 25 years. So you can see a very slow and gradual evolution all the way to the most recent introduction, deep learning about 15 years ago, and then ChatGPT a couple of years ago. And suddenly you see the explosion that is driving AI in healthcare. And the interesting thing is that this kind of trajectory can also be seen if you were to look at the funding and investments, if you were to look at approvals for regulatory for regulatory approvals in the AI space as well. So you see a similar kind of spike over the last few years as there's been more and more interest in trying to build AI models in the healthcare domain. So what kinds of questions could we start to answer with AI is one of the things I'm going to be talking about today. So for example, you could have patients who've been diagnosed with cancer. Over here, you can see kind of a typical clinical workflow, diagnosis, some kind of neoadjuvant therapy, surgery using pathology to evaluate it, follow up, and so on. And one of the key pieces here is that for a lot of these patients, we're acquiring biopsy samples, so tissue samples from the tumor, we're acquiring imaging data. And so the question is, could we start to use this information to start to drive patients down different pathways, for example? So patients who may be responding, maybe they could be more actively evaluated. Patients who are having, patients who may having a partial response, they need to be sent to surgery. So we start to personalize the pathways in cancer treatment using the information being acquired for these patients. I heard, so as in addition to oncology, I also work in a lot of non-oncological conditions, such as in this case, chronic, in this case, digestive diseases. So Crohn's disease is a digestive disease, afflicts many children every year as well as adults. And one of the questions, again, similar to the questions that we see in cancer, a question is what pathway should we be kind of recommending for patients? And that's kind of a big dilemma for clinicians. Should they be getting medication? Should they be getting some kind of intervention? Should they be going to surgery? And so again, the question is, how do we start to inform this kind of decision? And so if you were to think of it, there's kind of a continuum. You have patients who respond on one end of the scale over here, and then you have the patients who have actually adverse reactions, not doing so well on the other end of the scale. But a lot of the times, the current clinical paradigm is a one-size-fits-all, kind of a standard dose given to everyone. And where we need to be trying to move, or kind of the vision of where we would like to move, is the idea of precision medicine. So personalizing the dose, so the standard responders get a standard dose, the adverse responders, so patients who have complications, get alternative doses, and then the non-responders, maybe they just get higher dosages and so on. And so how are we going to try to get to precision medicine? In this talk, we're going to be considering kind of multimodal medical imaging data, such as radiology, pathology, and so on and forth. And we need to kind of bridge the gap going from this data all the way to that precision medicine idea. So how are we going to try to bridge the gap? Well, one piece is we need to kind of convert the information that we're getting from the images into patterns, into predictions. So for example, this is an MRI image, kind of there are stats in the kind of multiple sections through the kind of the body over here. Or in this case, this here is actually a digitized pathology image. So this is a tissue sample from a biopsy slide or a resection slide that we then scan, almost like you scan a piece of paper at very high resolution, where you can kind of see the internal structures and so on and forth. And so this is also an image, just like a picture we might take with a camera. But what we can do now is once these are images, we can take these images and start to analyze them. So for example, we can run operations to extract measurements. So in this case, this is a heat map showing you different measurements of heterogeneity. Now red is a high measurement, blue is a low measurement. You can do that on the pathology data as well. We can also use multi-layer neural networks, so a deep learning model, for example. So we can take these images and kind of iteratively optimize information being extracted from the image to capture specific types of data. And then based on these radiomics and pathomics and deep learning approaches, we can then start to build groupings and start to classify between different types of patients. So responders versus non-responders, or try to prognosticate the outcome or survival for patients over a period of time. So with all of this, we'll be able to get from this idea of medical imaging all the way to the area of precision medicine. And so let's talk a little bit about the different types of diseases and applications which could benefit from these approaches. So the first study I'm going to talk to you about is in the context of colorectal cancers. So over here, what we're looking at is a patient who's been diagnosed with cancer. We've taken a tissue slide from this patient, and we're now looking at that tissue slide. That's what you're seeing over here. But now this image, as I said, we can analyze it using advanced models. So we can use it to go in, identify where the tumor is on this image. We can identify the cells that are present in the image. So we can identify where the tumor cells are, where the immune cells are, different types of cells that are present on the image. And then we can start to extract features from them. And then these features can be visualized over here. Different colors correspond to different cell types. And you can actually see that the cells on the left, this is a patient who achieved complete response to chemoradiation. So the tumor was killed off by chemoradiation, versus a patient who achieved only partial response to chemoradiation. That's the image on the right. Actually have very different signatures in each case. And then if we were to take this information and drive a model through it, we actually find that combining information from the different cell types, which is this red bar over here, gives us the best overall performance in determining response to chemoradiation. So like I said, if we could identify the patients who are going to benefit from chemoradiation, we can start to move them down alternative pathways where maybe they don't need to undergo surgery because they've done their tumor has been killed off. A more recent development in this space is this idea of foundation model. So foundation model is basically where we take data coming from multiple different institutions, multiple different diseases and cancers. You take millions of slides and you try to automatically have the network learn what information is present. So we can take all of these different images and build a model that is a representation of the information that's present within the image. So now you may be asking, okay, so how could we use this information? What does it really, what does the information really mean? So there's been a lot of work in trying to understand how this kind of large scale foundation model kind of approach can be utilized. So here I'm going to be showing you some work in the renal cancer space that we've been doing, where what we've actually done is we take these slides and then we take the entire region and then we actually break it up into a whole bunch of tiny little tiles. And then these tiles can be run through each of these different colors correspond to a different foundation model. So gigapath, workout, these are all individual types of representations of the information that's present on the slide. So now we can take this kind of abstract representation and start to apply it to questions such as, can we start to understand what the grade of the tumor is on the slide, just without ever having to evaluate the slide? Could we automatically start to give an indication as to where there may be high grade or low grade, where the tumor may be more aggressive, to assist the clinician in their decision making? So what this could look like, for example, is if we were to take all of these individual models, we actually found some interesting results. It actually turns out each of these models, if we were to try to look at what regions are important to them, we actually find that they look at all over the place. So some models are looking inside these red regions, which are tumor regions. Some models are looking well outside the tumor. Some models are looking only at the tumor as well as the surrounding benign regions. So there's kind of a lot of chaos, or there's a lot of uncertainty between the models in trying to figure out what is the most important region to try to grade where the cancer is. And so this is kind of, in some sense, this is somebody who, if for a naive user, if they were to be given a slide and say, hey, tell us where the tumor is, they have no idea what they're looking at. And similarly, foundation models also don't seem to immediately know what to look at. So if we were to try to guide them a little bit and say, okay, why don't you work between yourselves? Why don't you start to put your heads together, so to speak, combine the information from different foundation models, we actually get a much more interesting result. So over here, this image over here is actually the same exact slide. The red contours are where the tumor is. And what you can see is when you're trying to understand how aggressive or the grade of the tumor, the model is correctly looking, this heat map corresponds to where the model is looking at. It's actually showing you very nice overlap with where the tumor is, and it's ignoring all the benign regions, the healthy regions, which would obviously not be very relevant from a cancer grading perspective. And so this kind of allows us to start to build models which are more intelligent by starting to combine the information coming from across all of them. So we can take information coming from different models. We can also take information coming from different types of features. So we can put those foundation model features with what I described previously, the different types of cellular features, and that actually starts to boost our performance in identifying more advanced aspects of the disease. So we can start to understand how well a patient has responded to therapy much more accurately than if we were to use either of these regions separately. So now that we can analyze the data in different ways, now let's think about how to use it in a multimodal fashion. So, for example, if we had the MRI and we have the pathology, can we start to use the multiple modalities to understand better what might be going on? So over here, for example, we have, for the same patient, we have a region, we have the digital pathology slide that you can see, and then this is the MRI over here. And so what we did is we've actually developed approaches which allow us to combine between the image on the top and the image on the bottom over here. And so when we do that, we can overlay the pathology image onto the MRI image. And now we can actually start to take that information that we were seeing, the different types of cells, the different types of regions, and start to understand what those look like on the MRI directly. And we had fairly good performance at doing this. We were able to map between those regions with a very high degree of accuracy, less than a 1 millimeter error in mapping between regions. But why this is important is you can start to use this kind of approach, mapping the pathology data to the MRI or any other type of imaging to inform what you can learn on the MRI itself. So as I said at the start of the talk, we can use this in the context of oncology, but we can also use it in the context of non-oncology. So we actually did this in the context of Crohn's disease, for example. So in the context of Crohn's disease, we actually got matched pathology images together with MRI. And now this green outline here is where the disease is present. And this is a sample of the pathology. And when we map between them, we were then able to learn signatures to now not just tell you, where is the disease, but on the imaging directly start to tell you how severe the disease is. So is it disease which is highly fibrotic? Is it disease which is highly inflammatory? Are there other aspects going on? And then we're able to relate those radiomic features to specific pathologic aspects of inflammation versus fibrosis. So, for example, what radiology features correspond to the level of mucosal fibrosis, ulceration, neutrophils, and so on and so forth. So that's great. So we can use imaging to try to predict what might be going on with the pathology. That's cool. But how is that actually useful to the clinician in a decision-making context? Well, what we can do is we can actually now take these signatures to try to predict the outcomes for the patients, which is what clinicians are more interested in. So can you tell us which patients are high risk versus which patients are low risk? So here in the case of Crohn's disease, we were able to take a group of patients, some of them who are low risk, who were stable to routine therapy versus the high-risk patients who kind of had lots of issues with the standard medication being given to them, and analyze those exact radiomic, the image features coming from those patients. And you can see over here, the low-risk patient has a very different appearance from the high-risk patients with a lot more red versus a lot more blue. And now we take this information and we can start to augment the radiological evaluation of the exact image. So you can also have the radiologist look at this image. And then when it turns out that when we combine this radiomic, the AI model together with the radiologist evaluation, we actually have very high performance in segregating between the high risk and the low risk patient, where the high risk patients are in red, the low risk patients are in blue. So we're actually able to separate between them very, very accurately. And most critically, we're actually able to identify 100% of the high risk, where individually the AI model, the radiologist were only able to identify 60, 70% of the high risk patients. As you can see in the figure next to it, where you can see a lot of overlap between the blue and red curves. So with that, I'm just going to pause my talk right there, and I'm happy to take any questions or go back over any of the material I spoke about. But the idea is that we can use computational imaging, artificial intelligence tools to learn signatures across pathology and radiology to inform disease assessment, and then even start to build multimodal models which can augment performance in disease characterization and risk stratification. I'd like to thank once again the organizers for giving me this opportunity to talk to all of you, the funding agencies which have made this work possible, and I'm my research group, the group that I direct here at Emory University, who, as I like to say, do all of the magic, and then I get to tell you all about it. So with that, I'm very happy to take any questions, and of course, my email address is on the slide in case people would like to get in touch.
Thank you, Dr. Vishwanath, for a brilliant talk. We have time for just a couple of questions. Very fast, please, short answers.
I'm Dr. Purvesh Parekh, medical oncologist from Tata Hospital. In your work, have you found the value of stroma in addition to the malignant cell morphology that could influence the decisions?
Excellent question. We actually, so I skimmed over some of that in the interest of time, but we actually found that when we take this information coming from different models, it's actually not just paying attention to the tumor, it's actually paying attention to some of the stromal regions and so on, which are very proximal to the tumor. And we're now in the process of trying to analyze this in more detail. And we saw this across multiple cancers. So this is in colorectal cancers. We also saw this in renal cancers. So the short answer is yes. The longer answer is yes, both in the pathology, and we've also seen it on the MRI side. So we can look at in kind of mapping that stromal region and trying to understand the details from the MRI.
Thank you. Thank you, Dr. Vishwanath. We had a few more questions, but they will need to get in touch with you on email in the interest of time so that we move forward and be in time. Thank you so much. Once again, a round of applause, please.
Moving on to the next speaker, computational pathology is opening new frontiers in personalized medicine. For to give us a definite introduction to that, I would like Dr. Yuan Ritamero to enlighten us. I request Dr. Siddiqui Ahmed to chair this session.
Good morning, everyone. It's a privilege to welcome all of you to the exciting conclave on next generation computational pathology. Pathology is rapidly evolving from conventional microscopy to the digital pathology, artificial intelligence. I would like to introduce Dr. John Retamero. He is an internationally recognized for his work in digital pathology and AI-enabled diagnostic workflow with deep expertise in pathology operations and technology-driven diagnostics. His work has focused on advancing the adoption of AI in histopathology, strengthening diagnostic efficiency and accuracy, and supporting the integration of digital pathology into modern clinical practice. Good morning, John Retamero. I'll invite you to address this gathering who are excited to hear your talk. Thank you.
Hello, everyone. Good morning. My name is Juan Tamero. I'm an anatomical pathologist, and I'm here to talk to you today about foundation models in pathology. Before we dive in, I'd just like to thank my friend and colleague, Dr. Vina, for a kind invitation to be here today and essentially to share some of my experiences with you. As an introduction, I would have to say that I was very fortunate to be one of the pioneers in complete digital pathology transformation for routine diagnosis. That led my career as a pathologist to really evolve from that of a diagnostic pathologist to essentially a consultant that advises organizations into their digital transformation journey, and of course, the implementation of AI solutions into their workflow. I have been quite fortunate to be working for Page for the last 5.5 years. Let me start by essentially trying to define foundation models. Foundation models can be tricky to understand, and I hope that by just providing a few key concepts, this becomes easier. First of all, it's worth mentioning that foundation models are AI models that have been trained at very large scales, including sometimes millions of whole slide images that have been essentially digital counterparts of the humble H&E slide. So that's the first thing. Foundation models are trained on very large scale. The second thing is that foundation models to actually learn patterns. They try to see what the pattern behind the actual tissue is. So foundation models try to identify things like perhaps inflammation, things like perhaps neuroendocrine features, things like perhaps what makes perhaps a lymphovascular invasion different to a perineal invasion, and things like that. So foundation models try and identify these patterns present in the tissue. Another key feature is that foundation models tend to be quite adaptive and versatile. And essentially what they are is the scaffolding upon which we build something bigger. Hence the name foundation models, because essentially they provide the foundation upon which we can build a different model fine-tuned for a specific task. Foundation models also share two key characteristics. The first thing is that they tend to be self-supervised. Essentially what that means is that when we think of an AI being trained in pathology, the first image that comes to mind is actually a pathologist creating annotations. And in fact, foundation models have not been trained using annotations. We make the slides available to the model, and we let the model figure out what those intrinsic patterns in the tissue are there. Foundation models do not require, for the most part, of the annotations of pathologists to basically learn their craft. That's the first characteristic, self-supervised. The second characteristic is that they're transferable, because they tend to be very general, because they tend to be trained at massive scales, these foundation models learn to see patterns that transfer very well across different tissues. So essentially the models tend to identify perhaps inflammation, not just in certain organs, but also across other organs. So this transferability is also one of the key characteristics of foundation models. Why are foundation models in vogue today? Why the buzz about foundation models? Well, essentially foundation models represent a paradigm shift for AI in pathology. The reason for that is that the models that we've seen in computational pathology thus far have been models that have been trained with a narrow task in mind. Let me give you an example. So for instance, a prostate algorithm. The prostate algorithm is largely designed to find foci of cancer and then to provide a Gleason scoring on that particular tissue. So essentially, we're looking at a model that is narrowly trained in a certain tissue type. If we try to extrapolate that model to detect cancer, perhaps in a different tissue type, the model will most likely not do very well. Essentially because the models have been trained with a specific purpose in mind. And when we apply the same model to a different purpose, they don't generalize very well to that other task. For that reason, we say that these models tend to be single organ focused, be that prostate, be that breast, be that perhaps lymph node, etc., etc. And they're very good at a single task, but they do not generalize very well. So for that reason, they tend to be quite limited in their adaptability. So that is how AI has been in pathology over the last few years, over the last decade. With the advent of foundation models, this is actually changing because essentially foundation models are trained in very large data sets that tend to be quite varied as well. So, a foundation model can be trained using millions of slides from different topographies, from different organs. And this means that these foundation models actually have multi-organ capability. So essentially, they learn to recognize patterns across tissue arising from different locations within the human body. This means that these models tend to be multitask and quite versatile. So perhaps not just apt at perhaps finding cancer, but also quite good at finding other patterns like inflammation, lymphovascular invasion, perineal invasion, etc., etc. So essentially what this means is that they can be quite broad in their clinical usage. So for these reasons, I'm firmly convinced that foundation models will become the future of AI in pathology in the coming years. Let me also introduce a few other concepts that are very important to understand foundation models. One of the most important concepts is zero-shot learning. And essentially what that means is that the model can perform tasks without having been explicitly trained to identify that task in particular. And it does so by relying on their previous experience. Let me give you an example of what does. Let's imagine that, for the physicians in the room today, let's imagine that I told you a case of, a patient that presents to the emergency room after having been, hiking in the mountains. And this patient basically presents with a targetoid erythema that actually keeps getting bigger. And this patient also describes some facial weakness and some facial problems. Certainly the first thing that comes to mind to most of us should be perhaps, suspicion of Lyme disease. We suspect that even though many of us have not probably seen a Lyme disease patient ever in our lives. But essentially what we draw in is from a background in medical training, from a background as physicians, we get the information that we need to properly identify the solution to the problem that we're looking at. So essentially that is what zero shot means. That means that given the broad context and the broad exposure to many data, models can actually solve problems that have not been specifically trained for during the training phases. So that is one of the key concepts that foundation models can do today, something that obviously all the models could not certainly address. Pre-training. So pre-training is another key concept to understand foundation models. And the way that I envision this is similar to how we train pathology residents today. So essentially, what we do during pathology residency or any other medical specialty for that matter, is that we put our residents, our trainees, the subject to exposure to a huge amount of data. And essentially, the hope there is that the resident will learn to identify certain patterns. And in that sense, that's how foundation models learn. So we expose the foundation models to large amounts of data with the hope that they will pick up what makes inflammation an inflammation, what makes cancer, what makes perineal invasion perineal invasion. So in that sense, the pre-training concept is similar to the residence aspect in medical training. The next concept is fine-tuning, and continuing with the medical training analogy, this is like doing fellowship. So essentially, we got a model that has been trained in general subjects, and we want that particular model to be specifically sub-trained with a certain special interest in mind. So that's where perhaps residents go on to do a fellowship in perhaps GI pathology or derm pathology, whatever the case might be. Essentially, what we're doing is fine-tuning that trainee into a specific task. So in that sense, fine-tuning a model, meaning we take a generalist model and we provide a specific sub-training for a certain task. Okay, so very, very similar in that regard to how doctors are trained. Embeddings is another important concept to bear in mind. And essentially what an embedding is a mathematical summary of the most important features present on a tissue. And embeddings can be provided at a whole slide image level, so providing essentially a mathematical summary for the whole slide, or rather for a part of it, which is what we call tiles. So essentially a tile will be a fragment of that slide. And the idea is that that embedding, that essentially mathematical vector, conveys the essential features for that tissue present either on a whole slide image level or on a subtile subset of that image. But again, embeddings essentially is a mathematical summary of the most important features present at that level. We touched on the self-supervised aspect earlier on, but essentially self-supervised meaning that the models discover the patterns by themselves without human intervention. So they discover these patterns quite autonomously without the need of a pathologist basically telling them what's cancer, what's inflammation, what's the individual pattern that we want to decide. So essentially the model learns to identify the patterns even though they do not have a name for it. Finally, we have the concept of uni or multimodal foundation models. And essentially what this refers to is the type of data that has been used to train that model. So in that regard, we have vision models in which only images have been used to train that model. We have language models like ChatGPT and Claude and Gemini, etc., which essentially they've been trained in large amounts of language to emulate the response and the interaction that we would have with a chatbot, with quite similar in that regard to interacting with another human being. And then we have multimodals, foundation models, that essentially what they do is that they marry visual images together with a text. And essentially that's what we do with multimodal foundation models in pathology. So essentially we provide a model with the whole slide images together with the pathology report. So the model learns to generate essentially reports akin to essentially what pathologists do today. Another way to understand how foundation models operate would be with the pyramid analogy. So essentially the foundation model provides the base upon which a future model is built. So let's assume that we want to train a foundation model based algorithm for identifying, diagnosing GI biopsies. What we do is that we provide the base of the pyramid, the trunk of the pyramid, that essentially is provided for by a foundation model that has been trained in several million slides. And then we fine-tune that model, providing a subset that in comparison could be quite small. We provide that subset with a specific task for which we want to train that model. So if we want to train a model specifically for GI biopsies, we could provide a specific subset of annotated or weakly supervised. So essentially what we mean by weakly supervised is the level of intensity, the level of supervision with which those slides have been annotated. And that could basically provide the subspecialism for that particular model. And of course, in AI parlance, that's what we call fine-tuning the model. So again, the base is provided for by the foundation model itself, and then we fine-tune that model with a subset of data to create a super specialist in a particular area. Okay, let's look now at the advantages of foundation models. But essentially the key advantages is that foundation models, because of the broader training, they tend to be better at detecting cancer, including rare histological variants of different tumor types. And essentially this is an example paper published in Nature Medicine a couple of years ago, where our group looked at essentially comparing traditional AI models with a foundation model-based algorithm to detect cancer in any tissue, what we call pan-cancer detection. If you look at the pink bars, that would be the performance, the area under the curve of the pan-cancer model. And essentially we compare this new pan-cancer model against other models, some of them FDA approved, in the detection of different histological subtypes of different tumors. So here we have perhaps prostate tissue, where we pit the two models against each other to see which one was better at detecting rare histological variants like neuroendocrine tumors, atrophic tumor, foamy cell subtypes, lymphoma, etc., etc. We do see that the pink bars are taller, for the most part, than the other bars, meaning that pan-cancer was better at detecting even these rare histological subtypes. The same could be said about breast tumors. And we can see here how, again, the pink bars tend to be better than the non-pink bars at detecting rare histological variants like adenoid cystic carcinoma, metaplastic subtypes, mucinous carcinoma, secretory carcinoma, exceedingly rare. But we do see that essentially this pan-cancer foundation model-based trained model essentially learns the secretory morphology perhaps in different organs and applies that same paradigm, that same pattern in the recognition of these tumors in the breast. So again, remember the concept of zero shots and remember how the model essentially learns to perform a task based basically on its background, on its broad training, and can essentially identify very rare histological variants better than other models that have been trained specifically with a certain pathological task in mind. Good. So to start, I'm sort of wrapping up my session today. What do I think the future of the profession would entail? Three things that I'd like to mention. First, multimodal AIs that essentially will evolve to become comprehensive oncology foundation models. How do we do that? Well, essentially integrating clinical records, imaging, molecular data, and treatment and outcomes data into a unified system that by looking at all of these inputs could basically create a prediction as to how a certain patient is going to evolve, how a certain patient is going to respond to a certain therapy, and what the overall patient outcome is likely to be. And I think this is becoming a reality that is getting closer and closer. Another aspect would be co-pilots in pathology. So essentially an AI that will in itself engage other AIs to help pathologists do what they do. And essentially what that would look like would be a co-pilot that it becomes a cockpit through which the pathologist basically operates that can fetch radiological data and put it at the disposal of the pathologist. Quite useful when we do it, perhaps, breast specimens that we need to refer to the, to the original radiology data to get a cross description or to get, information about the specimen that we're dealing with. Clinical history data. Perhaps if you're dealing with a liver biopsy, it's quite important to know, is this patient immunosuppressed, what's the clinical history, etc., etc. So all of that information could be at your fingertips thanks to AIs that basically summarize the clinical history, distills it, and puts it at your fingertips immediately. The third aspect would be personalized medicine. So, foundation models can help us analyze patient-specific patterns to predict what the optimal treatment would be for that particular patient. So with that, I'd like to thank you very much for your attention today. I hope my talk was of interest. Would be delighted to remain in touch. And if there are any questions, please feel free to send them through via email. I'll be delighted to get back to you as soon as possible. Thank you very much, and I hope to see you again. Bye-bye.
I thank Dr. Juan Ritamero for his beautiful presentation. This definitely shows us that AI cannot replace pathologists. Rather, it will help them work smarter, shifting from glass slides to pixelated pipelines. For our next talk on pixels and patterns, I request Dr. Rajendra Singh to please come for his talk. I request Dr. Suma to please chair this session.
Hello, everyone. Good morning. Transitioning from the conventional glass slides to digitized pathology needs a pipeline of several steps. To give us a knowledge on this, we have Dr. Rajendra Singh. We all know him. He's an expert dermatopathologist. He's an academic in pathology and laboratory medicine with expertise in pathology innovation and digital workflows. His work has contributed to advancing digital pathology systems, intelligent diagnostic workflows, and the integration of technology-led innovation in pathology practice. His focus is on improving efficiency, accuracy, and translational impact on laboratory medicine. And for him, it is midnight now. He's from University of Pennsylvania. So he's live with us, and we should take maximum use of it. Welcome, sir. Good morning. Good morning. Yeah. Early good morning to you.
Thank you very much. Thank you for the invitation, and I hope you can hear me clearly.
Yes, sir. Yes.
Good morning to everybody, and my name is Raj Singh. So thank you to the organizers and Dr. Veena for the invitation. I'm going to talk about the topic that I was asked to talk about is pixels and patterns from digital slides to intelligent workflows. And you can see, like, as already mentioned, like I'm a dermatopathologist, so I sign out cases all day. And pathologists are normally trained to look at patterns. So in residency, in fellowship, you are trained to look at patterns, and through those patterns, we can now make a diagnosis. But in the last couple of years, we have seen that besides patterns, pathologists also have now to understand what is a pixel and what is the importance of these pixels. because through these pixels that we see on a digital slide now, it's not only about a diagnosis, we can get a lot more information from that image about prognosis, about treatment prediction. So the pixels are becoming very, very important, as important as the pattern. And that was the reason this title was chosen, Pixels and Patterns, because those are now becoming the bread and butter for pathology diagnosis. Just as a disclosure, I'm the founder of Path Presenter platform. So when we come to digital pathology now, when we have like digitizing the department, digitizing all our slides, we know that we are generating like petabytes of pathology data, which far exceeds the data that is coming from radiology or genomics or even your clinical data. The amount of data that is being generated from pathology is way much more than any other kind of data. And like for an example, like a small department like Sinai or University of Pennsylvania or MSKCC, they tend to generate around 3 to 5,000 slides per day. And this is just one department. And each slide in pathology, as you all know, it's like roughly 1 to 2 gigabytes. Some can even be like 10 gigabytes in size, but the average size is 1 to 2 gigabytes. So 3 to 5. So this like easily like translates into terabytes and petabytes of data every year from each department, and roughly around 1 billion slides are produced every year, so that you can like see the amount of data that pathology is generating. But and with the data, what has happened is we have seen that a lot of other technologies have come across. So we now see a lot of algorithms, as we already saw in the last presentation, a ton of algorithms that have come to pathology. Many departments like HCG have already completely digitized. So there's a lot of digitization that has already happened. And as we saw, a lot of different foundation models have come across now in the last couple of years. So all this is now a solved problem. Like foundation models are easily like they are easily available, multiple of them, algorithms are multiple of them. But what the issue is still that when I go back to my department, even at the University of Pennsylvania, we are not using this AI with the digital slide. So what is the problem there? What hasn't been solved is how do you bring all of this together? The workflow of bringing all of this together, the integration of bringing all of this together, and then also ensuring that there is a governance of the AI, like who is responsible for the AI, how is the AI explainable, all that governance and the ethics that is associated with the use of the AI is all like put in place before you can start using these algorithms. So how can all of this be delivered in a way that the pathologist or the oncologist or the clinician can use it? And I think that is what is still not being solved. So the diagnostic, if you look at pathology, which was always about diagnosis, now that has almost become like a sliver of the value that you can get from the digital slide. There's a whole lot of value that can come from the use of AI from the digital slide. And that is what we're going to talk about today. So when you think about a pathologist or even like an oncology person who wants to look at a digital slide for any kind of use case, there are multiple steps involved. So like first, like even before I look at a slide, there is some pre-screening that's going to happen that can help me make sure that I do my job in a much better way. Then like when I'm looking at the slide, there is a lot of now tools available that will again help me do my job in a much better way and actually help the clinician provide much more relevant information to the patient. Then we can definitely augment that once the decision has been done, like how can you augment the decision to provide additional information, and then how do you manage that data to use it in a much more effective manner. So now diagnosis has just become like one part of the entire equation that can come from pathology. So there's a lot of other things that can happen now when we talk about pathology. Okay. So when we start up with the pre-screening, like there are no so many AI tools that can now help me do my job in a much better way. There are like already like Johan already in the last talk already referred to the pan cancer model. The pan cancer model can actually look at the slide before I come into the department and screen the slides and give me like whether the slide has any kind of cancer or not. And like many people get stuck on like, is this going to be accurate? Like even if it is 80% accurate, and if I can get 80% of my cases sorted out in the morning that this is cancer and this is non-cancer, it is going to be a big boost to my work because I can take care of those cancer cases at a much very early in the morning, so that the clinician on the oncologist and the patient on the other side can get the report much faster. So, and then it can also like help me like make sure that the quality of the slides is maintained. So there's a lot of quality control that can be done even before I look at the slide. So no time is wasted. If the slide is not of good quality, it can easily be screened and rescanned or reproduced as needed. The cancer cases, like I said, can be separated out from the non-cancer cases. So any immunochemistry, any molecular testing that needs to be done can eventually be ordered early in the morning. And like I already alluded to, like diagnosis is now just part of the thing that a slide can give us. Basically, there's so many other information that we can get from the slide, like what are the underlying molecular alterations. It can predict a lot of them. Is the patient eligible for any kind of specific therapy? What is the prognosis? Any companion biomarkers? All of that information can now just come from that digital slide. And here is an example of one of the AI models for melanoma that can prepare, that can like predict the risk stratification and separate the melanomas into a high risk and a low risk melanoma. Just from the digital slide, not even doing any kind of molecular testing, not doing any kind of genomic testing, just from the digital slide, it can give me prognosis for that melanoma. And you have seen all these now in prostate, you have seen that in breast. So a lot of information can now be generated from the slide. We can also use the AI to ensure that I can do my job in the right way. So any errors that are occurring in the report can easily be caught by the AI. So like here is an example of one of the reports. So when I'm signing out like 100 cases a day, my focus is on the diagnosis. I don't read the entire report, but if the AI can tell me like, please stop and look at this because in the clinical history it says it's the left arm and in the diagnosis you're saying in the right arm, then this can be flagged immediately even before I sign up the case. So a lot of this can happen before I sign up the case. So a lot of AI can now help me make sure that the reports that are going out are checked before they go out. So whether there is any mismatch in the laterality, any mismatch in the site, in the gender, any required fields that are missing, all of that can now be already pre-checked and made sure that the AI can allow me to be much more efficient in my work. So all this, once they start coming in the workflow of my daily work, there is so much improvement, there is so much efficiency that can be brought in. And like when I sign out the case, the report is a PDF report that then gets stored and no information gets extracted from the PDF report. But now we have tools that can extract the information so that that information can go into a registry, can be used for research, can be used for clinical trials. So for an example, like if I'm like looking for cases in my department for some kind of research, and for example, if I want to find a metastatic melanoma in lymph node, that were given neoadjuvant therapy and that did not respond to the therapy. So they have more than 50% viable tumor within the lymph node. So if I want to find those cases, it is a long process because I have to go through a lot of different systems to find those records. If I first go through the pathology reports to find the melanoma cases, then go to take that same patient and go to the records for the treatment and see whether they were given neoadjuvant therapy, then go to back to pathology in the lymph nodes and see whether they responded or not. So a lot of loopholes before I can find that information, and this normally takes a lot of effort from multiple people and time to get those reports out. But now we have systems that can extract this information and put them in a way that I can find it very, very easily. So there are like tools that can extract the information from the report, sort it out, and make sure that it matches the exact terms that a researcher would look for, and then save it basically. And this can then save a lot of time for the researcher. So again, AI coming to the rescue to help sure that more efficiencies are brought to the department. And now we are actually at UPenn, we are working on a tool which can do this automatically. So we have this agentic framework that we are creating, which can extract the information from the report, then bring it into a concept library and make sure that it is stored in that concept library. Then there is a matching agent that takes these concepts and matches them to like a SNOMED CT or a OMAP directory. And if it is not matching, then it allows the supervisory agent to make sure that it can match up to something. But if the supervisory agent also cannot match it, then you allow it for human review. So all this allows the human burden to drop almost like 90%. That human does not need to get involved in creating this library that can be universally searchable. So a lot of this thing is already happening in multiple departments where data can now be easily extracted and stored in a way that researchers can find it very easily and use it for any kind of research. And even pharma companies can use that data to find the right kind of patients for the companion diagnostic drugs or for research. So now we can find that information in less than 24 hours. So the gist of that, like 10 minutes isn't enough to talk about all the different workflows that we have started to bring using AI into pathology. But the gist is the data is what is now being generated, and that is going to allow us to like not only provide a diagnosis, but also help the clinician like get better prognosis for the disease, get a pre-treatment prediction for the disease. And I think that is where the entire power of digital pathology will start coming through, where it helps the oncologist and the clinician get much more information from the pathology slide rather than just the diagnosis. And I think that is where the next decade will be one for pathology becoming the center of precision medicine by integrating these kind of workflows into our regular work, basically. And I think that is the end of my talk in 10 minutes. Yep.
Data is our power, and use of that data for healthcare is the power of AI. I thank Dr. Rajendra Singh for his beautiful talk and inspiring vision for the future.
Thank you very much, sir. That was a very enlightening 10 minutes talk. Do we have any question?
Good morning, sir. Just one question. You said before sign off, you can predict errors in your report, right? Is that automated by any AI solutions, or are there any models which can do this error prediction before report sign off?
Yeah, so right now we have like actually created small, like people are now calling them agents. We can call them tools that actually look at like information within the EHR, which is the clinical record. Then they look at the information in the LIS, and then they look at the information in the report that is being generated. And they just match it up, like what is the site in the EHR, what is the site in the LIS, and what is the site in the report, what is the gender. And so at least all those things are easily being caught even before the report is being signed out. Then anything that is missing in the report, the agents or the tools can easily now point out that, Raj, please wait, you haven't put in this information in the report that is critical for the diagnosis. So those things have now easily been solved, and they're already being implemented in the department. Even like timestamps are being created for every step in the, so when the case comes into the department, when the case goes into grossing, when the glass slide is produced, when the digital slide is produced, when it goes to the pathologist, and when the case is signed out. So all those timestamps, we know the timestamps, so we can easily like figure out like what is the time that's spent between when the case came into the department and when the case got signed out. And there is a time limit. If it is extending beyond 48 hours, the agent will immediately flag that case has been delayed. So all this is now being implemented at multiple departments across the country right now.
Thank you very much, sir. I think if you have any questions, we can mail him directly.
Behind every successfully treated cancer patient, we have a diagnosis of a skilled pathologist. To share real-world insights from the front lines of oncology, I request Dr. Veena to come for a talk on breast biomarker in AI. And I request Dr. Sumana to chair this session.
Good morning, everyone. It's my privilege to introduce Dr. Veena. She would not read an introduction, actually. And today's topic is adopting the breast biomarker workflow in the laboratory. And artificial intelligence is moving from the research laboratories to day-to-day practice. And it is very important that it is just not important that we adopt the sophisticated algorithms, but the reproducibility of it is very important. And in today's session, we'll be having a valuable insight into the practical steps and the challenges which are involved in this. And I welcome Dr. Veena, who's a distinguished expert in histopathology and digital pathology with extensive experience in oncologic pathology and technology-enabled diagnostic innovation. Her work has contributed significantly to strengthening cancer diagnostics, advancing digital pathology adoption, and supporting the integration of pathology with precision oncology, translational research, and data-driven clinical decision-making. Welcome you, Dr. Veena.
Thank you so much, Chairperson, for the introduction. Can I have the slides, please? So what I'm going to talk today is the practical implementation of a breast biomarker algorithm, that is ERPR HER2 Ki67, in a cancer hospital, Like how did we implement it, what changes we had to make in our workflow, what are the challenges we faced, and what is the learning of implementation. So this is the flow that I'm going to present, that what is the challenge of the microscopic interpretation of the breast biomarkers. All of us as pathologists are aware of it. And how does AI help in overcoming these challenges? And then what workflow modifications to suit an AI into our workflow we had to do. How did we validate the AI? And what is the experience out of this implementation, and what is the lessons that we learned, so that it is useful for people who are looking at the AI implementation in their laboratories. So as pathologists, we all know that the ERPR, HER2, and Ki67 is one panel of the immunohistochemistry markers that are necessary for any patient with breast cancer, because the treatment decisions depend on the expression of these markers. And we all are aware of the challenges that we face when we try to interpret this on the microscopes. So the challenges are several, of which the most important ones that I consider, which have an impact on the patient management, are the inter-observer variability, or what we call as subjectivity. So there are publications which say that this sort of inter-observer variability varies from 7.5% to almost 25%. So which is a huge difference, and this can impact the patient management. And in our labs, we have had this challenge of addressing these pre-analytical variables, and particularly in a country like us, where we get samples from different sections of the society, and the way the tissues are handled has always been a challenge. So tissues are not fixed, and the recommended fixative is not used, cold ischemia time is not monitored, fixation time is not monitored. So when you do an immunohistochemistry and then you end up seeing no staining, so you are in a dilemma of that, because whether you should be really signing out this as a negative interpretation. Then lack of reproducibility. So there have been studies which say that a pathologist who has interpreted a biomarker and then again goes back to the same slide probably after 3 months or 6 months and tries to interpret, there is a bias in interpretation, or a reproducibility is significantly affected. And publications say that this can vary up to 25%. Then if you have a weak staining, like particularly with a HER2 and then ERPR, then you end up spending more time on each slide. And now with the regulatory guidelines coming up, making things much more clear. So if your pathologist is not trained and not aware of the latest updates, then you also end up having a challenging interpretation from a pathologist. So this is where the AI models actually help the pathologists in streamlining the diagnostic reproducibility. So, as you heard from the previous speakers, digital pathology and generation of whole slide images is a basis for implementation of any AI model. So if you had to do a digital pathology implementation in our laboratory, you had to do the validation of your scanner, both the hardware and the software, ensure that it is able to reproduce exactly what you see under a microscope, modify your work processes to fit the images to the scanner and the slides to the scanners, train your technical staff, your pathologists, your residents, so that they are comfortable using the whole slide images, and if possible, to integrate with your LIS. So when we started with our digital pathology workflow, this was the quality of the slides that we had, which we were using for our microscopic interpretation. So at the end of the digital pathology implementation successfully and validation, this is the quality of the slides we have in our laboratory today. And the comfort levels of the pathologists on interpretation of whole slide images was also evaluated, which initially was at 97.3%, and with a proper training and a day-to-day use, it became to almost 99.3%. And good digital images are basically necessary for the AI implementation, because AI performs only as the slide quality. So when we looked at the implementation of this breast biomarker algorithm in our laboratory, the first thing we wanted to address is the pre-analytical variables. So we put in efforts to control document the cold ischemia time, control the fixation time, and we had to train our OT staff, spoke to our surgeons, seek their cooperations, and we also monitored at our laboratory level. And then we defined our SOPs, trained everybody so that we don't deviate from the SOPs. And our technicians had to be trained on the slide preparation techniques. That is, we had to train them on we had to train our residents on the grossing techniques, the tissue sections, the thickness of the sections, then the processing schedule had to be tweaked, and then the embedding techniques had to be tweaked, because the section has to be exactly in the center, properly embedded, made into a proper mold, and then the section when they take should exactly be in the center of the slide. So all these had to be trained, our technicians had to be trained on all this. And followed by the review of every slide before signing out the report, to make sure that it matches what we are seeing under a microscope. So when we started initially, there were slides which had this quality, the one you see on top, which under a microscope probably we would have still considered and reported. But when we implemented the digital workflow that was necessary for an AI implementation, this is the quality of the slide that we actually worked on. So the implementation of AI happened in a stepwise manner, starting from the validation, and then changes in the workflow, then ensuring that the pathologists are comfortable using the model and also are comfortable with what they see under a microscope and are comfortable with the comparisons. We had to put in a lot of strict quality control measures to ensure that the AI is reproducing what a pathologist sees under a microscope. And then we started documenting our experiences. Where did the AI fail and why did it fail? And then started working on it. And still, we did face challenges, and how did we address those challenges? So the algorithm that we used basically was a deep learning algorithm based on the semantic model. And this is an IVD-CA approved algorithm that we actually used. So for the internal validation of these breast biomarkers, we selected 80 cases. Sorry, it's mentioned as 60. We selected 80 cases each of ER, PR, HER2, and Ki67. So ER cases were of different staining intensities, like 0 to 2, then 3 to 4, 5, 6, and 7 and 8. Similarly, the PRs. And HER2 was 0 case, 0, 1 plus, 2 plus, 2 plus, fish negative, 2 plus, fish positive, and HER2 3 plus cases, and Ki67 of different intensities, less than 14%, 14 to 30%, 30 to 50%, and more than 50%. So this was the selection of cases that we had for internal validation, and each pathologist actually went through each of these, the slides again, recorded their ground truth, and then looked at scanned the slides, and then applied the algorithm and looked at the algorithm interpretation. So the concordance rate was at 98.3% for ER, PR was 97.7, HER2 was 98.1, and Ki was at 97.8%. So we had to implement our digital workflow for the application of AI model. So the technicians were trained on scanning all these IHC slides into the scanner. They were also trained on looking at the quality of the slide, which is a good quality slide. I'll be enumerating that in my subsequent slides. They were trained on that, identify good staining slides, and then the pathologists were applying the AI models on these slides. And then simultaneously, they also looked under the microscope, and then concordant results were signed out. Wherever there was a discordance, the pathologists did a manual review of these cases and then finally approved these results. So I've just put it here, the average turnaround time, because anything that you do always comes with a question: has it improved your turnaround time? At this point, I would say not really, but at a level where you see under a microscope and a level where you see on an image, probably there is an improvement, probably by 1 or 2 minutes with the application of AI. But definitely AI has helped the pathologists in improving their confidence levels wherever we have challenging slides. So we did a pathologist satisfaction survey. If you look at these parameters that we had given to them, everybody was happy with the quality of the images that they had used for interpretation, which correlated with their ground truth. They were happy with the annotation tools that were used for the use of the AI, and the counting Ki67, they were very happy because you know how difficult it is to count Ki67 and HER2 because of the heterogeneity. And they were not that happy when there was a compromise slide. Whenever there was a weak staining, the AI always interpreted that as negative, whereas the pathologists could identify some weak staining and they were able to interpret. And whenever the quality of the slide that was stained was not good because of the tissue issues, they were not that comfortable. So if you look at the positive aspects, the Ki67 and tissue heterogeneity were the positive findings for them, and the negative were the weak staining and the quality of the slides. So we, with this in mind, we started working on looking at every slide, trying to identify why the AI is not able to interpret and how do we improve on the accuracy of the AI model. So for which we also implemented certain quality control measures. So we already had scanner quality control on a day-to-day basis. So we implemented the stain quality measures. The technicians were trained to look at the images and document the quality of the image, whether there was a tissue loss or thick sections or sections had folded, whether there was a lot of necrosis. All these were actually documented. And with every case being interpreted on the whole slide image as well as the manual microscopy, we in fact implemented a monthly review of a 10% of cases that we had reported in that month. So 10% were again pulled out, the images were reviewed, they were fresh fresh annotations were made, and then those were compared with what the pathology sees under microscope to ensure that the AI is performing as per our requirement. Discordant cases were definitely reviewed as and when we came across the discordances. We also defined certain deferral criteria. That means the slides which we do not want to use or where we do not want to apply the AI for interpretation. So all these were defined based on our views on the whole slide images, the AI model's sensitivity and the specificity, as well as the pathologist's comfort levels. How comfortable is the pathologist on reporting such cases? Then we started documenting the reproducibility, that is intra-observer reviews every 3 months. That is, the pathologist who has reported a case pulls out the slides again after 3 months and then reviews it again and looks at the concordance, both under the microscope and on the AI model. Inter-observer reviews again every 3 months between the 5 pathologists that we are there. And whenever there was an upgradation from the vendor, we always did a revalidation to ensure that it performs to our satisfaction. And periodic revalidation if there was a change in our staining protocol or the clone or the way that we are making the slides or any changes in our tissue processing protocol. All these were used as criteria for revalidation. We do participate in the external quality control program for the ERPR HER2 Ki67 whole slide images, and the performance has been good. And we also participate with the breast biomarker programs, and the performance has been really good with all the measures that we have implemented. So far, what has been our experience, what we like and what we don't like with the AI, with the breast biomarker AI, is that it's very good as wherever you need to count. That is, Ki67 is very good, counting is very good because it addresses the entire heterogeneity in the tissue. And it is also very good if you have a HER2 equivocal case, because this interpretation is based on the HER2 amplification. The algorithm interprets based on the amplification. So you can actually defer the case for FISH, or you need not do FISH on these cases. So and it also addresses the heterogeneity. So this is what we like with the AI model. What we don't like is whenever there is a weak staining, the AI struggles. It's usually gives a different interpretation than what a pathologist would interpret. And it does not help us in overcoming our pre-analytical challenges that we have, that we encounter even in our microscopic interpretation. And as of now, it requires a constant monitoring. Every slide has to be reviewed by the pathologist and then only signed out. And now we have algorithms. I mean, at that time, actually, we didn't have an algorithm which could interpret HER2 low and ultra low, but now we have algorithms that are available that can interpret HER2 low and ultra low. And clinical acceptance is something that it's still, we need to work on it. And and in our hospital, because we sign out reports saying that it has been interpreted on the algorithm, but it is also verified by the pathologist. So that is the disclaimer that we use, and that has been clinically accepted. But as we don't have regulatory guidelines, that is something that is lacking. So as I said, KI is highly reproducible and addresses the heterogeneity. So these are the two practical benefits that we see apart from the HER2 equivocal cases. So these are some images that I would just like to show you. So you have those annotated areas where you see a very weak staining of, this is a ER case, so there's a very weak staining. So AI would usually interpret this as negative. And there is some background staining which it will interpret as positive. So this, you have to be very careful. And there is that side is a case where you have a tissue folding with lot of necrosis. So because of the tissue folding, and this will be taken as a high number of cells, and the interpretation can vary. So this is a necrotic area where you have some membrane staining which can be interpreted for false positively, and you have stain precipitates here, especially if you are interpreting Ki67, this can be counted as a proliferative index, and it can be a high Ki. So what we learned so far is KI is an excellent tool which helps the pathologists wherever there is difficulty, particularly with the Ki67, addressing tissue heterogeneity, but still requires a human to supervise its work. So just to wind up my talk, with our experience with the implementation of breast biomarker definitely says that AI is here to assist the pathologist, but not to replace the pathologist. And it definitely requires a pathologist to supervise its performance and a regular monitoring, because these are patient samples and have huge clinical significances. So pathologists should adopt AI and see how best they can make use of the advantages, benefits of AI to their advantage. So thank you so much.
Thank you, Dr. Veena, for that excellent presentation. She has given us a practical insights into the analytical, pre-analytical, analytical, and standardization and even validation. And it's a commendable job of achieving this sensitivity and specificity comparable, and more so than the available studies on this breast biomarker models. Thank you. Any questions?
Challenge on HER2 new, ultra low HER2 new versus negative HER2 new.
Models which basically are able to interpret HER2 low and ultra low as per the Destiny 4 and 6 trials. The current models are available.
Thank you, ma'am, for showing us how we can easily integrate AI into our pathology department. Your work continues to inspire us. By now, we have learned that the biggest power of AI is converting multiple man-hours into minutes or seconds of AI work. To improve efficiency, our next talk is by Dr. Sujay Prasad. I would like to call Dr. Shabnam to chair the session.
Good morning, everybody. Artificial intelligence and digital transformation are redefining the clinical laboratory by streamlining workflows, improving diagnostic accuracy, and enabling faster, smarter, safer, and more efficient patient care. To talk about this, we have none other than Dr. Sujay Ram Prasad, who is here, needs no introduction, but I'd just like to read out his introduction here. Dr. Sujay Prasad brings experience in diagnostic laboratory systems and workflow optimization. His work has focused on strengthening clinical laboratory operations through process improvement, digital transformation, and the adoption of technology-enabled diagnostic systems, with an emphasis on enhancing efficiency, turnaround time, and quality across laboratory workflows. Over to you, Dr. Sujay.
Thank you, Dr. Shabnam, for the kind introduction. A very good morning. At the outset, I would like to thank Dr. Veena for giving me this opportunity. It's really a pleasure to be here, not because I'm standing here and talking, but more because of the learning that I'm having over the last 4 or 5 talks. It's simply amazing. My talk is more of a break, because it's not going to talk about the microscopy, the digital slides. It will be talking more about the digital transformation that is essential to AI. So what I'm going to do is give a brief introduction. I know I have to pack all of it in 8 minutes, 8 to 10 minutes. I'll quickly a start on the timing. Understanding digital transformation and artificial intelligence is very important. And the way I would like to share this with you is digital transformation is an organization-wide redesigning of processes. That's the way digital transformation has to evolve and happen, and it's happening. And digital transformation is the basis on which data is generated. Whereas artificial intelligence uses that data to convert it into meaningful, actionable points. The value that digital transformation brings to us, in my mind, is far more than at this point what AI can do. And it's immediate that we experience the value with digital transformation, whereas with AI, it is taking time. And like Dr. Rajendra Singh mentioned, I heard him talk last year at the ASDP as well. We meet once in a year, we talk fantastic things about AI and what it's capable of. But when we go back to our labs, we are back to square one. And he brought out those reasons very well on what are the things that we are struggling with to actually implement AI in our workflows. So when you look at other aspects, digital transformation can be measured quickly. And there are clear measurable parameters that we can look at. Whereas with artificial intelligence, it's hard to attribute, and benefits are often probabilistic. And failure consequences. When digital transformation fails, the process slows down. But when AI fails, it's often hidden, and those challenges are far more. The wrong output can propagate at scale. So we need to keep this in mind. So my focus will be more on digital transformation rather than AI. But it's also how do we as humans relate to AI? And I think it's important to look at what do we identify ourselves with? Do we identify with matter, physical body, mind, or awareness? And the mind itself has 4 aspects: memory, ego, mind, which is the thinking capability, the cognition or intellect. When you look at each one of them, they all have different human response to AI. Let's take memory. If I identify myself with memory, so far I was good, but now AI has memory that is far exceeding what a human can have. And that brings terror to me. I feel very intimidated. When it comes to intellect, all of us are sitting here very curious to know what AI is capable of. Our behavior, our response to AI will be that of curiosity, probing, and trying to be analytical. If we look at ourselves as pure awareness, who we truly are, but we don't realize that, we look at it with equanimity, with just a witnessing a person and have no stake in the entire process. There are many areas that I would like to take you through, but in 8 minutes, I don't think I'll be able to do that. I'll quickly take you through the challenges we have always had in terms of errors in registration. And these are the 2 tables that comes out of our laboratory information system where 11 staff have done the registration for our accessioning. And you see that there are many modifications that are done subsequently. And most of these modifications are done because primarily the first time they did, it was a wrong entry. So the first keystroke is also always very important. But if we don't measure that, we are in trouble. In the management jargon, it is known, if you cannot measure something, you cannot manage it. So let's start measuring what we are, and that's where we are at. A 2.54 sigma is pretty low, but I didn't even know that it was that low. Digital transformation starts to build that kind of understanding, that measure, that gives us an understanding that 1 in 7 registrations required demographic amendment. I was not aware of that. And most of it was related to wrong patient identity or wrong clinical context, and it's very silent and goes unnoticed in the downstream as well. So before we were looking at quality measured at the department level, but now we are looking at a sigma metric for every person on my staff who's registering. That gives me a clear understanding of what is happening with individual. So each registration is an opportunity where defects can happen. Any demographic field which is later amended is considered a defect, and that is quantified. This is a typical scale of sigma, and this is where the 11 staff have been provided with their scores of what their sigma levels are. If you look at the best performance, S05, she has reached, or he or she has reached a sigma of 3.01, and with targets of clean 227 registrations in a month. We also know the first name and age are the biggest challenges. The errors that happen in our lab are related to these two, and amendments are made. 80% have reached the error defects are first name, age, referred by, mobile, and title. All of these now give us a powerful indication as to what changes we'll have to do. So the entire process is fair by design. We are not trying to do all of this to be punitive. The idea is to give information. If I'm the person who's doing the registration, I quickly have a way of improving myself. So we have all of this now automated. What can happen in future? I think we have real-time prompts that can come even before defects are allowed to happen. So you can only improve what an individual can own. So once the individual owns the measure, the sigma, then he or she can improve. And we gave a kind of a report to the staff on their performance and where they can improve. Coming to the examination process, this is something, a 50-year-old male with massive splenomegaly, complete blood counts, and this comes out of the cell counter. And the cell counter also provides, that's my colleague looking at the digital data. The cell counter also gives scatter plots, which we try to use to make sense of and guide us in trying to see what cell type we should be looking at. When in a typical normal case, the centroids of all the three clusters gives you an equilateral triangle. But when you try to apply that to this particular case, it doesn't fit in. And a pattern like this is very unique. In another plot, you see that there's a set of events that are happening that are not seen normally, and those events are seen as cells with moderate amount of cytoplasm and hairy appearance on the. This is a case of hairy cell leukemia. If my pathologist colleagues look at the cell counter scatter plots, they're able to immediately understand that this is a case of hairy cell leukemia. So what we did now is we are trying to see if we can look at patterns of scatter plots and try to make sense of it. Primarily because the scatter plots don't have a numerical correlate or pattern for us to make sense of. And when we gave the scatter plots to the LLM, the foundation models, we had different views of the same. And we are now trying to see how do we utilize that in our workflow. Looking at the post-examination and particularly sigma is a good measure of errors. And the reason why I always go after errors is quality is absence of errors in a given system. So I don't go after quality, I go after errors. And sigma is a good indicator of quality within a given system. So what we do is, I'll limit myself to the examination phase where we look at sigma of all the parameters that we are running, particularly in the chemistry area. And we have 3 models, 8 guidelines, 12 values, 7 machines, 20 pages each, 100 row items. So there's a lot of data, not necessarily morphologic or imaging data, but a lot of numeric data, and all of them contribute to a lot of information. How do I convert this into meaningful information? So we have to extract data, and we used to take 15 days for all this to convert to a sigma that I can decide on. I will quickly go through. with data science building a portal where we can convert some of it into digital, it reduced to 2 days. But we didn't stop there. We went on to have a collaboration with an engineering college, and we looked at agents to look at some of these activities, and now we get it on the first day in 30 minutes. I'll quickly go through the last. This is something that we are trying to look at, the workflow in surgical pathology, looking at the grossing itself. We are trying to see if we can measure, describe, and transcribe gross images into meaningful description. And this has worked well, so now we are trying to see how do we integrate it into our workflow. Pathologist stands for about 6 hours grossing, but we are trying to see can we take the help of LLM to help them complete their activity in shorter time. So in summary, digital transformation is essential to realize AI. Often errors help in identifying areas for digital transformation. In fact, AI is a layer that adds thinking to the current digital workflow, and asking the right question is a prerequisite for a meaningful AI journey. Thank you very much.
Thank you, Dr. Sujay Prasad, for the lucid talk and very enlightening. Do we have any questions for Dr. Sujay? Yeah, you explained it very well, so there are no questions. Thank you, Dr. Sujay.
Thank you, sir, for showing us how the crossover between statistics and AI is helping us reach new heights. Moving on, we have learned so far a lot about AI, but to really implement it requires a clear vision and a lot of grit. For this monumental transition, I would like to call upon Dr. Richard Rumnong to guide us through this, and I request Dr. Nishina to please chair this session.
Yeah, thank you so much. Good morning, all. Firstly, sorry, a little personal. Thank you, Dr. Veena, for inviting me to chair this session. It's going to be a pleasure because we are also implementing digital path at Narayana Health later this year. And I'm actually, being the head of department, a little nervous as well as very excited about it. And I think your topic is really apt, Dr. Richard. I really want to know upgrading surgical pathology and transitioning into integrated digital as well as AI ecosystem.
Yes.
Over to you. Thank you.
Thank you so much. Jendra, in bringing up the topic of workflow and why it's so important in delivering quality in terms of the surgical, in terms of surgical pathology. Why is it so important? And Dr. Veena, thank you so much. You've illustrated the entire process, right, from cold ischemia is becoming so important. So basically, if we are able to manage the workflow, finally, when we're looking at digitizing and then AI, it really helps us in that entire process. Now, I'm very happy with the fact that we're talking about digital transformation, because I think that's the big step. Digital transformation has happened a lot in the lab, but primarily in the biochemistry and immunoassay areas. It's now emerging in pathology. And that's what I would like to introduce to you. What does digitalization in the pathology workflow look like? There's a lot of differences in terms of how you think of digitization because of the nature of workflow in pathology. Now, when you're looking at biochemistry, it's always one tube coming in and the sample is pretty much, you can repeat the sample at any point of time. It's not, it's akin to, when you're talking about digital, it's akin to having a precious sample. You can't repeat the sample. Your specimen comes in, that's what you've extracted, and that's what you have to evaluate. Also, another concept that is very common in terms of biochemistry, or uncommon in terms of biochemistry, is the concept of add-on tests. I need to add on one more test. It's very rare, maybe like 2 to 3% in biochemistry. However, when you come to pathology, it's the norm. Everything will have an HNE, and after an HNE, then only do you have an IHC. And that is over a different time period. So I come in, I get my specimen, I gross it, I process it, I produce a block, which is my main storage medium, and then I go for an HNE to get an initial overview. After that, I will give my IHCs. My IHCs also, I can have a second round of IHCs coming in. So over 2, over 3, over 5 days, that can go through repeated cycles. Now, what's happening is that not only the fact that I'm repeating requests on the sample, the same specimen that I have, I'm also varying it, and I also have to have a clear tracking mechanism. Because my slide, what it represents, is a section of tissue that has been processed from something that's been taken out of the human system. Now, it could be a small biopsy, it could be a excision biopsy, it could be a large specimen. So, all of that has to be mapped, and the fact that where the tissue has come from, it's working? Yeah, sorry. That's a little bit about me. Let me go straight into the talk. So, maybe I want to get these 3 topics clear through my 10 minutes that I have. So, what I'm saying is that in pathology, what is different from biochemistry, and why does it need to change? There is one patient case comes in, you have a one-to-many specimens. So you can have, in small specimens, you have one. If you have a large tissue excised, you have many. One specimen can have one-to-many blocks. One block can have one-to-many slides, and so on and so forth. You see, so the variation, and in this case, specimen has to be stored for 30 days. You need to go back to it if needed. A block needs to be stored for 5 years. You will go back to it for various purposes. A slide has to be stored for record purposes for 5 years. Very different from what you would do in other labs. And that's where the maturity of the digitization that has to happen in it will change. Now, to get to this for all of us who are in the medical field, we've been taught this. We've been taught this, our professors have been taught this. And it's an established process where we get tissue in different forms, small tissue, large tissue, very large tissue. We get all these specimens. We put them through pre-analytics, and then we go into primary staining, advanced staining, and imaging reporting. Now, the need, why is pathology comes, a large part of pathology is essentially determining how onco cases are. So that's where we're related to. A lot of pathology, yes, there's infection, there's inflammation, that's what you're looking at, but a large part of it is dedicated to describing oncologies. Now, given the demand for need of onco care today, you want to make your entire process repeatable. That means you can do it again and again and again. You want to make it effective. So every time you're doing it right. You want to make it reproducible so that every change in technician, every person who changed in the department can do the same job again. You want to make it efficient because you want to utilize the resources as best as possible. And very important, you want to make it predictable. That means this process will occur in this much time. Once you have this, you have scalability. Because you know your process is standardized, you can change it. Now, a lot of AI, a lot of discussion is about imaging. Imaging is one part of it, but that's the latter part, that's the end. Good process will give you good slides, will give you good imaging. This needs to be digitized because there's a lot of traceability when you're talking about slides. The slide is not just a slide, it's a culmination of all the efforts that have been put in to make that slide. So slide is what grossing was done, who did it, what microtomy was done, what processing was done, what tissue was there, what stain was done. Each slide has a different stain. If you have you're looking at only one slide. No, you're not looking at only one slide. You're looking at least 5 slides. So everything has to be digitized, and there's a bulk of information that's coming to the pathologist that needs to read it. So to give you a sense of this, most pathology workloads, you've got primarily H&E, IHC, which is primarily dedicated to oncology, and maybe a few special stains. But this is the truth. One patient can have one-to-many specimens, one specimen can have one-to-many blocks, one block can have one-to-many slides, and you have to look at it in reverse, because essentially what the pathologist is using to report is going to be a slide, and they have to know what block this came from, they have to know what stain was there, what block it came from, what specimen it came from, and what patient history was. This is all the information that has to be presented to a pathologist to make this decision. Very, very different from any other practice, and that's very important to digitize the entire process so you have this information ready. Now, this is an example of personalized medication. Why is IHC so important? Because you're unlocking cell expression to determine what treatment works best. So, essentially, if you're looking at breast tissue, and those who are not pathologists will not be able to tell me a difference. They're looking at brown slides. But though you're looking at brown slides, what tissue was used, what stain was used is very important. Because your stain here in breast and in gastric could be different, but they're all brown. So all of this is very important information to have so that you can interpret the slide that you're seeing better. Now, again, a lot of people involved in the process, skilled workers. Each histotech is very skilled in what they do, whether it's grossing, or in grossing you have a pathologist, then in tissue processing you have skilled histotechs, in embedding and microtomy, you have to have that skill level because it's very important to have the orientation right, to do the process right. So a lot more people need to be involved in the process. So it's not only about one person doing it, it's about a whole team working together and knowing what you're doing in a team. So when it comes down to this, in today's current scenario, you have this. You don't know who's doing what. You cannot track what's happening in your lab. And essentially, a lot of us are using registers and chits. Reality of the day. That needs to change. You need to look at errors. If you're finding errors, where do I find the errors in this? How do I correct? How do I improve quality of my process so my slides are great? If I do that, I get volume. So this is where I'm talking about introducing digital components in each layer so I can get this data and I can work with it. So something like this. So on LIS, my demographics, like a lot of errors come there. So how can I transfer all of those data into a middleware or something, an IT system that can help me manage that data, whether it's grossing, whether it's tissue. And you can see the small screens there. So each part has a digital interaction interface that allows me to understand, to present data to relevant data to histotechs, and then acting on that data and making this process transparent. So I have tracking, I know what they're doing, and everything is managed. So I have my timestamps, I have my action points, I have my data presented to the right people. And then when I put it into digitization, I've got the capability, because of the data in the slide, I've got the data to auto-assign it, I've got the data to move. So moving it, reducing time there, where that assembly takes time, or whether assignment takes time, I've got opportunities there. So that's about efficiency in the process. Once I have efficiency there, I go on to AI algorithms. Something like this, very similar, this is what I would like in accessioning, in grossing, in embedding, in microtomy, in assembly. Touchscreen interfaces that present data so that the histotech can act on it, because he's acting on it, or he or she is acting on it, it's registered, and you're able to trace the entire workflow as well as manage data correctly. Data like this becomes a cinch. It's not anybody entering the data or creating the data. Because action is happening, data is being created. And that can be presented, and that can be worked on, that can be evaluated. That's what we're talking about in digitization of workflow. Now, once we have that, as soon as you have a slide that has that barcode that is related to all this data behind it, you scan it, you can manage it by giving it to the right people, and then call on various AI algorithms to run on that slide. It reduces the effort it takes, and it reduces the errors that can happen in the process, or at least makes it more transparent. So AI, a lot of algorithms are available, and I'm going to call them, so it's AI-generated algorithms, because you're not actually using AI. AI, basically, when you're looking at it, you're looking at a method or characteristics that need to be identified, and then you're using an algorithmic process. So to run the entire image through an algorithm that has been generated or evaluated by AI, and then trying to make sense of that, whether it's counting, whether it's characterization, whether it's segmentation, all of that is what works here. This is what makes AI scalable in the future. Because you've digitized your process, because you know what you're doing through the process, when you present it to AI, this works. So, an end-to-end process, so being Roche, this is the solution. This is a workflow solution. If you see in the beginning, you've got all your stainers. Now, the benefit of stainers is that it's automated stainers. So the procedures stay the same. Now, what happens is that when the procedure stays the same, it is the CEIVD procedure that has been mapped, that when you do the stainer, when you run it on the stainer, you run this protocol, it has direct implications through guidelines. So guideline-enabled protocols that allow you to quantify tissue as everyone would in the globe. So your quantification stays the same, your ability to standardize what your diagnosis stays the same. Now, having said that, I couldn't have said it better. This is shown in 2023. I would really encourage you to talk about, to read this paper. It's called Digitization of Pathology Labs. I'm happy to share it with you or link with you. This talks about everything that is required to go about in terms of digitization of workflow. You will see here, if I just use the IT infrastructure is very important. That's something that you'll have to learn. Change management is what we've talked about of late, very important. And in the bid, you also have computer-aided diagnosis, but it gives you a sense of what needs to be done in terms of concordance analysis, quality control, digital reading, many things there. Very good paper, encourage you to read it, and that's what you take next. With that, this is the AI ecosystem that's developing. You'll see Path AI and Roche are there. In fact, now Path AI is Roche, so that's another step that we're moving in that direction. So we're really taking this forward. So with that, thank you so much.
Yeah, thank you, Dr. Richard. I'm so sorry I didn't introduce you, so if the introduction slides can be put.
Yeah.
Okay, so we heard from Dr. Richard Rumong. He is the lead healthcare consulting Roche Diagnostics India. He has 15 years of experience in medtech experience to his current role of lead healthcare consulting at Roche Diagnostic. He's an alumnus of IGMC Shimla, IIT Kharagpur and IIM Calcutta. He's at the forefront of deploying advanced pathology ecosystems across the country. As a part of his commitment to the industry, he recently co-authored key white papers and journal publications with CAHO aimed at benchmarking and improving the operations of India diagnostic laboratories. Thank you so much.
Thank you so much.
It was a wonderful talk. If there's any more questions.
Yeah.
Good morning, doctor. My name is Aditya.
Hi.
My question was, considering the way we are trying to integrate AI into our workflows, how far down the line do you think that an IT team in every laboratory or a hospital even matters? Someone who knows, who can initiate it and understand healthcare and AI.
So I don't know if you saw my slide. In my slide, I have one, when it's up, the IT team is very important. Now, that's something that needs to come into play. IT teams weren't really relevant in pathology labs earlier. You knew them as some guys who set up the LIS in the beginning and you forgot about them. But now what's happening is that they're core to your lab and core to your functioning. Because as soon as you look at digital workflows, you will have to also learn a lot of IT. So there's a lot of change management there. Pathologists will have to take up and learn little basics about pathology, about intersystems and how this digital transfer is happening. You'll also, because that's you're involved in that discussion, and you'll have to have your IT team who's there, who will be able to support you in the infrastructure that needs to be put up. So if you see the last paper, I did mention IT infrastructure. There's going to be a lot of IT infrastructure coming in. How do you understand it? And it's basic stuff, but it's important to open your, or overcome terror. Yes. So overcome terror, overcome fear. To kind of incorporate and understand this concept of what IT is. It's fairly simple. A lot of people know it. Don't make it a challenge. But once you understand that, you'll be able to incorporate this far easier, and it becomes a very important part of the IT people become a very important part of the lab. Thank you so much.
Thank you, Dr. Richard. Moving forward, as we know, we're moving into the future towards precision medicine. And what is equally important is to work for precision diagnostics. And cytopathology has always been a work of precision. I'm honored to welcome leader contributing to the world of precision diagnostics, Dr. Vani Ravikumar, for her talk on past, present, and future of AI in digital cytopathology. I request Dr. Sudha to please chair the session.
Good morning. It's my pleasure to welcome Dr. Vani Ravikumar. She is a known oncopathologist in the city. She will be talking on AI in the role of AI in digital cytopathology, the past, present, and future. She is an experienced pathology professional with expertise spanning surgical pathology, cytopathology, and laboratory practice. Her work reflects a strong engagement with academic pathology through conference speaking, postgraduate teaching initiatives, and cytology-focused workshops, alongside sustained interest in the evolution of digitally enabled pathology and diagnostic practice. Over to Dr. Vani Ravikumar.
Thank you. Good morning, everybody. At the outset, I thank Dr. Veena and the HAI Conclave organizers for giving me this wonderful opportunity to be talking about digital cytopathology and AI, the past, present, and the future. So cytopathology, which is the next frontier for AI diagnostics. So we are moving beyond the radiology. AI, we already know it has transformed imaging, radiology, the hospital workflow, etc. And so now the next major frontier would be the diagnostic laboratory. And in this, cytopathology, which is image-based, pattern-based, and data-rich, and it makes a very strong case for digital transformation and for AI support. So we are moving from the glass slide to digital diagnosis. Digital cytopathology combines a microscopy, the traditional glass slide, to digital imaging, use of a whole slide scanning, and AI-based image analysis, remote review, and digital archiving of these slides. And why is cytopathology a natural fit for AI? Because cytology is mainly a visual pattern recognition. We are looking at cells. The difference between histo, where we look at tissue, and cytology, where we look at the individual cells for making a diagnosis of a disease, especially in cancer. And cervical cytology screening, as you all know, for screening test for cervical cancer, it involves reviewing hundreds and thousands of cells. It is literally looking for a needle in the haystack, looking for those abnormal cells amongst the hundreds and thousands of normal cells. Sometimes these abnormal cells or the cancer cells are very evident, very obvious, whereas most of the time it is pre-cancer. So it is literally looking for the needle in the haystack, and it is here that AI can help us to identify these atypical cells and can prioritize the cells that need a closer review by the pathologist. So coming to the past, it was manual microscopy, early automation, and the traditional cytology relied on microscopy-based review. Screening large number of pap smears was so labor-intensive. The results was variable due to workload, fatigue, inter-observer variation, and early computer-assisted screening system. It did help us to some extent to identify the suspicious cells. Now coming to the evolution of the cervical cytology screening, we are moving towards standardization and towards intelligent screening. The conventional pap smear, the manual slide, we moved on to the LBC, that is liquid-based cytology, where the sample preparation, the unsatisfactory rates reduced. Then we moved to the computer-assisted screening, where early image-based support was there. Then to digital cytology, where the slide was converted into the whole slide image. And now we are moving towards the AI-assisted review. The algorithm will prioritize the relevant cells. The present AI-assisted digital cytopathology, what AI can do today in cytology: automated screening support, abnormal cell detection, cell and nuclear segmentation, benign and malignant cells classification, quantitative features, and workflow prioritization. The AI algorithm role in cervical cytology screening, we have moved from slide images to focused review. So always, earlier we used to tell in the lab, always give importance to the abnormals, because normal anyway you will be signing them out very fast. Give the time, your precious time, to the abnormals. So this is where exactly the AI will help us. The algorithm can detect the cells, cell clusters, segment nucleus, analyze the nucleus size, shape, staining, identify the atypical cells, rank the cells by the diagnostic relevance, and present the selected cells to the cytopathologist for the final review. So we are moving from the manual review of the entire slide, what you can see here. Look at the hundreds and thousands, the ocean of cells, normal cells, where we waste our time just looking at those normal cells. Whereas the AI-assisted prioritized cell gallery, where the AI will select, it will rank the suspicious or the relevant cells for a very focused review and greater confidence, and it will help in better patient outcome. When we integrate human with the AI workflow, AI will assist, the pathologist will decide. So the pathologist is not replaced. Sample collection, slide preparation, digital scanning, AI analysis, prioritize cell gallery, the cytologist review, final diagnosis and report. In everywhere we can see that the human and the AI workflow both will get integrated. What AI can improve in the lab, the potential impact on the lab operations, more focused slide review, faster prioritization, especially high volume screening. It will give us a lot of support, improves the consistency, better quality assurance, remote review. I can sit at home also and review them, and digital education and case archiving. So the case study, the challenge is manual screening of cervical cytology slides, which is time consuming, requiring high focus, high concentration to the AI solution, that is a digital scanning with AI-assisted detection, and the impact would be that more focused review, improved workflow efficiency, and easier case sharing and better teaching utility. So this is how it supports the cytologist or the cytopathologist in high volume screening. By the numbers, why it matters: thousands of cells to one digital slide, faster workflow, and AI prioritized detection. The challenges today: why AI in cytology? It is not so easy. There are a lot of challenges. One is the limited annotated data sets. You need huge number of annotation, the slides, the cells, the variable staining and slide preparation. If I see a slide, I will instantly know this slide is not from my lab, because we are so used to the staining pattern of each person's laboratory. Overlapping cells, complex background. The background could be hemorrhagic, mucus, debris and all that. Scanner to scanner differences, black box decision making. What parameters were used to make the decision or to give the diagnosis? False positives, false negatives. Sometimes I get second opinion review cytology slides. What is the error that has happened in the AI generated report? It is mainly to differentiate between the reactive changes versus the malignant changes. That is what we call the false positives, and regulatory and validation requirements. The challenges are, in cytology, the image may be not focused. In histo, we have a uniform 3-micron layer, whereas in cytology, the challenge is different dimensions, and it's all crowded and overlapped. What is the impact? Poor image quality, unfocused image, not suitable for cytology evaluation. Next challenge is a large file size. High resolution scanning, it will create the images which are very, very of large size, and the impact is the transmission between locations becomes very slow. The storing and retrieving the digital images could become very impractical. The next challenge is the scan speed. A typical, when we see a thin prep, which is the liquid-based cytology slide, there are so many, the time which will take maybe around 25 to 26 minutes. What is the impact of this? In a clinical setting, in a routine laboratory, we do not have that much of time to digitize the entire slide and all. It will too much of time, the scan speed is too much of delay. So to summarize the challenges in digital cytology, it's the poor image quality, the large file size, the slow scan speed, and also the digital systems which are designed for histopathology may not be suitable for cytopathology. Then coming to ethics and regulatory considerations, the 6 pillars: privacy, the secure storage of the patient's data; fairness, that is performance across the different populations and labs; safety, avoid the missed cancers and overcalls; feasibility, the infrastructure, the cost, etc. The governance, validations, audits, accountability; and equity, that is access for the underserved regions. Now coming to future of digital cytopathology, where is this field heading towards? A fully digital cytology lab, the AI-assisted triage and screening, and integration with HPV. So now, as you all know, cytopathology for cervical cancer screening, slowly cytology is moving out, HPV is coming in. So if you are able to integrate the HPV results also, that is the future of digital cytology. The cloud-based expert review, generative AI. I'm sure all the pathologists here would love to know more about this generative AI, which will draft the report and give us the literature support as well, and AI-enabled education, teaching, training, proficiency testing, etc. However, human expertise remains essential. The AI, it can guide the reviewer, it can flag suspicious cells, it can improve the efficiency, but the clinical judgment, the context, what we call the clinical context, or the clinical acumen, it still remains with the pathologist. So AI is like a GPS for a pathologist, but the pathologist is still the driver. The key takeaways: digital cytopathology brings AI into the digital laboratory. Cervical cytology is a strong case for use because it is image rich and screening intensive. AI can help to detect, prioritize, and organize the cellular findings. AI definitely improves the workflow support, but it does not replace the pathologist's judgment. And the future is human-led, AI-supported cytopathology. So AI helps find the cells, but the cytopathologist is the one who makes the final diagnosis. Thank you for your patient listening.
Thank you very much, Dr. Vani. It was very nice talk. So with your talk, we still will be in the field. That is for sure. So any one or two questions can be taken because we are running out of
Hi, Dr.
time.
Vani. I'm a pathologist for the last 2 decades. So good to hear digital cytopathology instead of digital surgical pathology. So my interest is on low yield samples like CSF, vitreous. What is your experience on that?
See, one point is low yield. So sir's question was a low yield cytology. See, when the yield is very good, obviously it's easy for any reporting, for any AI or any algorithm to pick it up. But when it is a low yield, I think initially the sample preparation time itself, if we improve the technology like adopting the liquid-based cytology, definitely some amount of unsatisfactory or low yield we can definitely address. That is from the starting from the root itself. The next thing is to catch those cells, to see the cells, and if there are abnormal cells, then even low yield becomes adequate. If you find the atypical cells, then even though the total cellularity is less, we will not call it unsatisfactory or low yield. We will definitely have to call it as a satisfactory and give the report.
Okay, thank you.
Thank you, ma'am, for showing us how AI will save our time and help us both in screening as well as in diagnostics. Till now, you would have seen the wonders of AI, but most of you must be wondering how to crack this complex algorithm. So let us welcome Dr. Vikram Sridhar, who will help us demystify the secrets of AI. I also welcome Dr. Renu to chair this session.
First of all, I'd like to thank the organizers and Dr. Veena in particular for having me here to share this session. I'm sure after listening to a lot of sessions by now, you'd agree with me that AI is not just about sophisticated algorithms. These algorithms are in fact used to create pertinent clinical solutions which are vigorously validated and also enhance the productivity and the efficiency of the pathologist. So let us see today what Dr. Vikram Sridhar, our esteemed speaker for this particular talk, has to say about it, and a little bit of introduction to him before he starts his session. Dr. Vikram Sridhar brings perspective at the intersection of pathology practice, digital systems, and artificial intelligence in healthcare. His work reflects engagement with the development and clinical translation of AI-enabled pathology workflows with a focus on digital implementation, validation considerations, and the responsible integration of algorithm-driven tools into diagnostic practice. Over to Dr. Sridhar, and we look forward to your talk.
Good morning, and thank you for the opportunity to speak to you all today. I am Vikram, a senior research data scientist in the NHS, working across applied mathematics, healthcare analytics, and artificial intelligence in imaging. In the next few minutes, I want to look at AI algorithm development for pathologists, not just as a generic introduction to the computational pathology, but as a story of how the field has moved from the narrow image classifiers to whole slide learning and foundational models, and why that changes what pathology AI can now attempt. For most of the history of the pathology, the slide has been something we inspect visually and interpret through expertise. What has changed is that the slide is now also a computational object. A whole slide image is not simply a photograph of tissue. It is very large digital representation of tumor architecture, cell morphology, stromal interaction, and immune context. That matters because it allows AI to do more than classify an image. It creates the possibility of detecting abnormalities, quantifying structure and patterns, and in some cases, predicting biologically or clinically relevant information from the routine histology. So the shift I want to discuss is not just a better image analysis, it is the conversion of histology into something that can be computed on systematically. If that is the broad shift, the next question is, why has pathology become such a fertile domain for AI? Pathology is particularly well suited to AI for three reasons. First, the information density, what it represents. One slide can contain millions of cells, tissue architecture, and microenvironmental context in a single image. Second, pathology has a natural biological hierarchy. The cells, the glands, and then the tumor bed, the invasive front, the whole specimen. So the same slide can be analyzed at multiple scales. Third, pathology often sits close to the labels that matter clinically. For example, the diagnosis, the grade biomarker status, the treatment decisions, and the outcomes. So pathology is not simply another imaging specialty using AI. It is one of the few settings where image data, the biological structure, and clinical meaningful labels come together in a particular rich way. That explains why pathology is attractive for AI. The next step is to look at how the field itself has changed. The field has changed in three broad stages. The first stage was task specific pathology, AI, which was basically tumor detection or mitosis counting, grading support, and a biomarker scoring. These models were useful, but they were narrow. They were built to answer one question at a time. The second stage moved to whole slide learning. Instead of annotating every nucleus or gland, models began learning from slide level labels across thousands of tiles. That allowed them to use much larger tissue context rather than isolated local features. The third stage is the current one, pathology foundation models. These are trained at scale to learn reusable tissue representations rather than a single diagnostic rule. That is the important shift. The ambition is no longer just to recognize a lesion. It is to learn tissue representations that can be reused across tasks and linked to prognosis, biomarkers, or molecular information. That is the strategic evolution of the field. Methodologically, the progression looks something like this. So this slide represents the progression of pathological AI algorithms. The earlier stage was a patch classification. The model sees a small image, a region, and solves a local task. For example, tumor versus non-tumor. These models are relatively simple, but they depend on labeled patches or regions of interest, and they only see a very limited part of tissue. The next stage was detection and segmentation. Here the task is not only to recognize abnormal tissue, but to localize structures explicitly, like nuclei, glands, mitotic figures, or tumor regions. This is a significant step up because the model has to learn boundaries, counts, and spatial localizations rather than a single patch label. It also creates a very high annotation burden because those structures have to be marked explicitly by experts. The third stage is a whole slide weak supervision models. Instead of annotating every cell, the model is trained from slide level labels and learns across thousands of tiles from the whole slide image. That reduces the dense manual labeling, but it substantially increases computational complexity and allows the model to use broader tissue context. The current stage is what we call as foundational models, multimodal modeling. These models are trained on a very large slide collections to learn general tissue representations that can later be adapted to multiple downstream tasks and linked with outcomes, biomarkers, or molecular data. So the methodological progression is from local classification to structured localization to whole slide representation learning, and with increasing the context, increasing the computational scale, and progressively richer biological questions. Therefore, once the ladder has been climbed, AI 3.0 has solved some older problems but it has also created some new ones. The first was the annotation burden. Earlier models often depended on dense manual labeling, and every nucleus, every gland, every tumor region. AI 3.0 made it more feasible to learn from slide level labels. A weak supervision models or a large scale pre-training enabled this. The second improvement was reusability. Instead of building one model for one narrow pathology question, it became possible to learn a broader tissue representation and adapt it across multiple tasks. But AI 3.0 did not simplify the field, rather it shifted the bottlenecks. The data burden is now much higher. The large slide corpora, the reliable metadata, the curated cohorts, and the linked outcomes. The computational burden is also much higher because of the large scale pre-training, and the whole slide modeling are pretty much expensive. And most importantly, validation becomes harder, not easier. A model that performs well in one cohort still has to survive many stain variations, scanner variations, tissue processing differences, and the messiness of the routine clinical practice. So AI 3.0 solved some narrowness and some annotation burden, but it replaced them with harder problems of scale validation and generalizability. And that is where the pathologies become central to the algorithm. The harder questions are no longer mathematical complexity or purely technical complexity. Pathologies are central to the algorithm development because in pathology AI, the hardest part is often not the network architecture. It is deciding what model should learn, what actually the ground truth is, and what kind of error matters clinically. Pathologists define those things. They decide what counts as tumor, dysplasia, artifact, or uncertainty. Where disagreement is biologically real rather than simply a labeling problem, and whether the output should be a heat map, a score, a count, or a triage signal. A technically strong model can still be clinically useless if it answers the wrong question. If the real need is to reduce missed microfoci or improve grading reproducibility or quantify tumor burden or prioritize cases for molecular testing, then those clinical objectives must shape the task from the beginning. So the pathologists are not simply validating pathology AI algorithms at the end. They are defining the target, they are defining the labels, the failure modes, and the place of the model in the workflow. That brings me to the final point. The significance of pathology AI is not simply that a few narrow tasks can be automated on a digital slide. The larger shift is that the routine histology is beginning to function as a computational readout of disease biology. Historically, the slide has been something we read descriptively, identify the lesion, assign the grade, describe the pattern, and report it. AI has pushed that boundary outward. First by detecting what is present, then by measuring what is difficult to quantify consistently, and now by learning tissue representations that can be linked to prognosis, biomarkers, and molecular phenotypes. That is much bigger change than automation. It means that a traditional H&E slide is no longer only a picture to be interpreted. It is becoming a source of quantitative and potentially predictive information about disease. The next decade of pathology AI will not be defined simply by better tumor detectors. It will be defined by whether we can turn routine histology into clinically trustworthy, biologically insightful. That's it. Thank you all. Have a wonderful conference sessions today.
Thank you, Dr. Sridhar, for the enriching talk. Within the interest of time, we could probably take just one question from the audience.
Thank you, sir, for showing us that pathologists will be the architects of the future of AI in pathology. Moving on to oncology, when we talk about oncological data, it's not just vast, it's multi-layered. It consists of genomics, radiomics, radiology, pathology, and much more. To coordinate this in an ecosystem, we need the glue of AI. To walk us through the multi-omics of oral cancer data ecosystem for AI-driven oncology, please welcome Dr. Nidhan K. Biswas. I request Dr. Urvashi to please chair the session.
Good day, everybody. Moving on now to looking at omics in understanding biology and giving us more insights in oncology. We have Dr. Nidhan Biswas. It's my pleasure to welcome him. He is a genomics researcher whose work spans cancer biology, multi-omics data analysis, and precision oncology. His research has contributed significantly to decoding the genomic, transcriptomic, and epigenomic landscape of oral cancer and oral precancers, with experience across major cancer genomic initiatives, biomarker discovery, and the development of AI and data-driven approaches for translational oncology. So with that, we look forward to your talk.
Thank you for the kind introduction. So I'm from National Institute of Biomedical Genomics. My name is Nidhan. Thanks organizers, Professor Chaudhary, Dr. Anita for inviting me. So today I'm going to talk about building the multi-omics oral cancer data ecosystem for AI-driven oncology. So this is kind of a shift from what we are hearing. I think by now you already know that what are the requirements for building, pathology data stack. So I'll be adding on another layers, which is the genomics data stack that is very popular in patient translation. So as I was talking that I'm from NIBMG and we work on these different multi-omics and data science approaches. So why I'm focusing on oral cancer? Oral cancer, as you know, is the topmost cancer among males in India, and here patient comes at a later stage in the clinic, and there is a high chance of recurrence within first 1 year of surgery, and there is a high incidence of local lymph node metastasis. So, and we need a solution because it's more of India-specific problem, because here people chew tobacco and in West, it's more smoking related. So we need an Indian solution based on this. And as tumor grows, this accumulates more, passenger mutations, and out of these, some of these driver mutations, they actually taken the tumor forward. And important thing is to, catch them early at different stages of the disease progression. And here, our primary focus, of course, to build this data stack or for the AI engine. Because if you have a very good ground truth data, then only your AI model will work better. And it's an India-specific problem, so from India we need to generate our own patient data. Of course, we can learn a little bit from the Western data, but this is where we are kind of on 4 tasks we are working on, generating a landscape, generating a pre-cancer to late-stage progression, understanding biomarker for metastasis and recurrence. So the general questions, I think, from the clinicians are, what if I do just to, standard approach and I don't do differently? Or maybe if I can put a treatment X versus treatment Y. In the lab, we guys think like, even if, we look at the clinical feature looks very similar, whether the biology is different because the mutations and the other landscapes are different. And of course, the patients have different questions. They need really confidence score, whether this particular treatment will give chance or not. So here, I think AI is very much needed in kind of precision oncology. And the thing that we are more interested in, early detection and screening, deep learning on oral H&E image, and to learn non-linear interaction pattern across genomics, imaging, and clinical variables, and simulate patient-specific treatment strategies using AI. And the whole idea, if we can build up this track, eventually we'll be able to, clinically map longitudinal clinical data, and we can have an early detection for recurrence and metastasis. And overall, if the larger goal, if we can make a digital twin of oral cancer using this multimodal framework, using data sets generated from Indian patient samples, that's the broader goal. But we need to keep in mind that what we are hearing from the morning, that if we have to use AI model, we need India-specific data, and it should come from Indian patients based on, here I will take up cases of oral cancer. what we normally do from the patient sample, we collect all of these biomarkers and eventually put them through molecular processing. And the third block, if you look at genomics, transcriptomics, proteomics, and epigenomics, all these, altogether called multi-omics. So we generate these data layers for Indian patient sample, and the aim is to put them into the AI engine. And to do this, of course, you need clinical collaborator. We participate with them. With these, we some of the ground truth data we have tried, creating from the Indian patient sample. We identified 10 driver genes, 3 molecular subgroups for Indian patient. And then I will show you one use case story where we actually have implemented on the genomics layer, where we collected a cohort from Karnataka only and looked into their genomic markers, which was kind of a validated cohort from our previous study. But what we have added here, from this biomarker, we gone to the histopathology image, which we are talking about from the morning. So we now mapped the genomics layer with the histopathology image and tried understanding that for a specific biomarker like EGFR, who works in orally, they know it very much. So we can directly connect in the EGFR tumors, there is lower abundance of tumor infiltrating lymphocyte, which we have got directly from the H&E image when we actually matched them. On the other hand, when there is a caspase 8 mutation with oncogenic TP53 or HRAS or PIK3CA mutation, we see more higher immune infiltration. So now what we can actually do, we can just directly go to the H&E image and directly predict from there. We do not have to generate multi-omics data. But we need to keep in mind this is only a study of n equal to 40, but now probably n equal to 400 or 4,000 patient sample is needed to replicate these across multiple modalities. And we kind of gone ahead and validated them in TCGA and other tumors. I am quickly going through it. And if you are interested, you can go into this paper where we not only have done this, we also clubbed single cell data sets with this narrative and identified another 2 patient subgroups where new treatment modalities can be thought through. So with this, I will go into 2 slides for pre-cancer to late stage progression. In oral cancer, there is a pre-cancer stage called leukoplakia. And what we did, we actually collected leukoplakia, tumor, blood, and adjacent normal from Indian patient sample and did multi-omics on that, genome sequencing and RNA sequencing. And the idea is, can we deconvolute? And what we have found out that there are these features that are mentioned here, caspase 8 mutation, EGFR amplification, chromosomal instability, with that immune suppression is a major interesting hallmark. And this came up in the Journal of Pathology cover in 2022. And we estimated it takes about 4 to 10 years for tumor to actually go forward and acquire malignancy. So this is a catchment time point where we can actually use digital cytology, then simple saliva-based screening, fragmentomics, and all these features, to put them into AI model and predict which individual will develop tumor and which who will not. So similarly, there is a concept called field cancerization. We also looked into it. And if you are interested, you can go and check. So what I am trying to impress upon that we are developing the input ground truth layer, data layer for AI engine to work on. I'll quickly summarize that another point on say metastasis. We have built a cohort for metastasis where we looked into the lymph node positive and lymph node negative tumors. And when we looked into their normal, demographic and other variables, they look very similar. But when we looked into their genomic profile, what you see, a lot of red dots on the right-hand side. And if you want to summarize them in one line, so it's basically chromosomal instability that drives metastasis. So now, from the genomic layer, you have a narrative. So we need to look at what's the, pathology narrative talks about here, and can we integrate them? So these are like our vision for going forward. More and more, we understood that it's not only the epithelial features that's important, but you need to pair up the immune features and the stromal features that everybody is talking about. And there are two technologies that are very important to look at. One is single cell biology and the spatial biology along with TCR interactions. So these are the things that we are doing for the next 3 years, and these data stack for Indian patient will be able to generate, which would be getting into, so this is basically a visual just for you to summarize. So as you see, what we are discussing from the morning, that there are thousands of studies, but eventually only a small fraction of that is going to the clinical lab implementation. The most important point my previous speaker already talked about, that the errors in data capture, metadata capture, I think that that's the single most big bottleneck in Indian ecosystem. All across last 16 years, whatever study we have done, all the metadata we have collected, that's the big problem that all of you have to solve at the day one. And of course, we, previous speakers talked about the digitizing the entire process. Who have done it, what day, what is the other variables are there. So once all of these are, in one place, and if we can make this data into one place, building the AI models is much easier. There are many other aspects our group is working. I'll be here for the next one day also. We can chat, and thanks to all the patients and their family members and the great team that we have, and funding from different funding agencies. Thanks.
Thank you, Dr. Bishwas, for a great talk. I think there's a lot of work there across different types of analyses, and we hope that this can someday soon lead to something useful in the clinic. I think due to paucity of time, we will not be able to take questions. So thank you again.
Thank you, sir, for showing that AI-driven oncology has a bright future ahead. From morning, we have been talking about creating and processing this data with the use of AI. But what comes next problem is the storage, what our next speaker calls the petabyte pathology problem. Our next speaker, Dr. Dayanand Papegowda, will guide us how to scale storage for this massive influx of medical data. I request Dr. Pankaj Gautam to please chair this session.
It's my pleasure to introduce Dr. Dayanand Papegowda from IBM. Dr. Dayanand Papegowda brings expertise in enterprise technology, data architecture, and digital infrastructure. His work reflects experience in building scalable technology environments, supporting large volume data management, and enabling robust digital systems that can underpin the storage, accessibility, and long-term management needs of data-intensive healthcare and diagnostic ecosystems. So we do understand how important the data and the data management is if we have to implement these solutions in our day-to-day work practice. So over to you, sir, and we look forward to a wonderful session from you.
Thank you, Hina. Thank you, HAI, for having me here. My name is Daya, as introduced. So I'm with IBM. So I've been working with as a consultant, global consultant for last 25 plus years with IBM. So given the time, I just want to go through some of these items quickly. So basically the outline is why data is important and some of the numbers that we talked about. Then speed versus governance, and also some of the strategy, right? How we can put this data. And finally, we have a case study with PathAI and some of the ethics and regulatory takeaways. So I know you have already went through some of the data collection, what happens. So usually it's more than 1+ petabytes of data every year per a large hospital network. Some of these data are based on US and other global numbers. So basically the increase in data is due to the whole slide imaging hospital networks. So we are seeing many companies owning China's hospitals now. Then again, model training pressure. The reason why data is important is, so every call, that you make to analyze, it costs money, okay? At the end of the day, whether it's hospital networks or hospitals, the first point they start is with either a revenue recognition to earn more or cutting down the operating cost. So along with other non-financial benefits. So here are some numbers. So it's almost, if you look at gigapixel multi-resolution pyramids, it's 10+ GB of data. If you look at 10,000 slides, it's almost 50 terabytes. And capex per 10K is almost 200K. So these are some of the numbers. You can look at the sources. It's CAP and CLAI regional variants. So histology blocks plus site retention is around 30 to 10 years. So depending on the regions around the world, there are compliances, there are HIPAA, there are a whole bunch of audit and regulatory requirements on how long you keep the data. So the more you grow the data for the storage, it costs more money. Okay. So speed versus governance, right? So from the clinical terms, yes, you want to have the diagnostic latency, multi-site access, clinical workflow. So basically every second is important, right? To access what, like all the data that you have collected. And also from an engineering challenge, it's the ingestion of data, right? So having a good scan is as a data storms that burns in hundreds of gigabytes of hours. So you need a proper IT infrastructure for that, be it at the hospital or be it at the connectivity between multi-hospital networks, or if you're using data from the cloud. So, and also the retention mandates, right? Regulators require slides, which basically keep it for 10 to 30 years, depending on which region you are from. And also the egress cost is the highest. So most of the things that you went through from the morning, so the folks that have done the language models, LLM models on the med models, most of them are cloud-based. So to access it, right, to retrieve the data, the amount of data costs you money. So every call costs you money. So that's one of the main important thing that we need to look at when we do the data. So, and also, so I'm going to talk about how you're going to handle this, right? So, because data is important. I mean, that's everything. Without data, you can't do any of the things that we talked about in the beginning today. So basically the layer strategy is you have tier 1, tier 2 and tier 3. So basically tier 1 is high performance data. So basically there are behind the scene there are technologies where we call the edge storages if you're on the cloud, or you need the sub-second pan zoom privacy. So within the hospital we have the caching network that we build so that you can have a high performance cache. The second one is the resilient object archives, because we take the immutable snapshots. What it means is it's a representation of data at a binary level. Okay, so this is important because whenever you move the sets of data across different regions, instead of copying the entire thing, we move the representation in a time. So for example, if you want to train a weekly data on an LLM, we don't push the entire data, but we just send the set of a snapshot, which costs us less as well. And there are cold migration by each case age, so there are multiple ways to store the data. So if you are not using it for 6 months or a year or 10 years, there are different levels of data, which basically cost different money for you to access on all the cloud providers. Okay. And also AI ready pipelines, right? So once you have this data, somebody needs to train it, or if you go against a model, right, that somebody already has built in, you need to have AI ready pipelines. So basically you need some good computing storage and a pipeline, which is basically from your data to the cloud. You need to standardize the metadata. So there is genomics or image functioning. So this was a case study, PathAI. They've just picked it up from the Google. So as you know, we had an earlier speaker talked about the RAS and integration with PathAI. So they had a challenge where from the data gravity and compute and compliance perspective, this WSI pyramids have severe latency because if it's a global viewing, right? So the earlier technologies and image viewing tools and capabilities, which introduced the latency for global viewing, and also training on billions of pixels demands elastic compute. So what it means is There are GPUs and huge changes happened within the last 2 years. And also, as you know, quantum computing is happening. So probably within next 5 years, whatever we are doing today might change entirely, right? So the problem they had that, and there were HIPAA and CLA requirements in Europe and stuff. So they wanted multi-site collaboration, right, for research and multi-chain hospitals which work around the globe. So they did use the Google Cloud. So there are some common standard healthcare APIs, which is DICOM, and also Vertex AI, now it's called the Gemini Enterprise. Google provides all the way from computing to storage and very good models, and for you to help on training your data, based off a model and getting the inference, okay? And certain technologies like BigQuery and all. So these are the data lake houses, data warehouses, wherein you can host huge amount of data, okay, which is across the globe. There are multi ways to arrange this data depending on the location that you are in, the region you are in, and the things that you are trying to do on data, okay? So then also for the data anyway, so from the ethics and regulatory, we have the privacy, because PI data is very important when it comes to healthcare, and fairness, right? So multi-site training, depending on the religion, creed, races, there are pretty ethical standards that have been already set. And also on a safety, right? Human in the loop is very important. I think we are in the beginning of translation of moving towards LLM-led medical diagnostics, right? So with more inputs, more data, and more training, I'm sure it's going to change much more. The error rates will be much less. Also the feasibility, right? At the end of the day, it's all TCO. So how much, it's all about the revenue and the operating cost other than the ethical stuff. But you need to be aware how to approach, right? How to go about building a strategy towards this path in the digital transformation, and aligning the latest technologies and clouds towards it. So just key takeaways. So the data is very important at the end of the day. If you don't have a tier technology, you won't be able to move it and basically build things around it. Okay, then there is a standardized on the DCOM, and these are the standardization, FHIR, the FHIR protocol. India has also moved into it, I think, last 2 years ago. Then push AI to the data, not data to the AI. So all the things that you see is, you need to work AI around your data, not that you give the data to the AI. And automate life cycle, retention and audit. So automating life cycle means having a strategy, right? All the way from your key KPIs on what you want to do with your data and what you want to do with the AI. And you need to have a good measurements when it comes to clinicians feel. Okay, so there are some references. You can reach me on my email as well. Any questions? Thank you.
Thank you, sir. It's very comforting to know how beautifully tech giants are solving the problem of storage. Let us learn more about AI-powered pathology platforms with Mr. Gaurav Kumar. I request Dr. Swarna to please chair the session.
Good morning. I'm grateful to Dr. Veena to chair for giving me an opportunity to chair this session. I know Dr. Gaurav Kumar is the business leader of the health informatics across India, subcontinent at Philips, a role he has held since 2002. With over a decade of experience at Philips, he brings deep expertise in driving health informatics strategy, business growth across the region. Dr. Kumar is based in Bangalore and continues to play a key role in advancing digital health solutions in the Indian healthcare ecosystem. Dr. Gaurav Kumar is talking on AI in pathology.
AI in pathology.
Yeah, I know it is a very interesting topic, as I am also a pathologist. Like, we know that we used to see the slides through the microscope. We had a very narrow vision. So where now Because of the AI and digitization of the slides, I think our view has become very wider, and we are looking at each lesion with a wider perspective. I think AI will definitely help us to give a very precision diagnosis, which is required for the cancer treatment. Thank you. And over to you, Dr. Gaurav.
Thank you, madam. It is pleasure to getting chaired by you, one of the old, very old user of Philips scanner. So quickly, I'll pick up. When we all have heard the lot of presentation which has happened till now, we have seen one challenge is there, which is adopting the AI. It's not about the challenge in the algorithm, because a few years back itself, we have seen the hundreds of algorithms are available right now, either in pathology, imaging, but the challenge is there in the integration. It is working as a fragmented, lot of manual work, getting those images, those AI on the your integrated LIS platform and all. So where the Philips is moving towards is, we are focusing on the 6 key area where we'll focus and improve the best utilization of AI for all the clinicians. That's the objective. So integrating the AI seamlessly. What it means? We have given you very advanced algorithm, but it is working as a silo. So we have a solution how we are going to address it. Open AI ecosystem, what we try to say it over here is, none of organization can fit their AI which can suit all your requirement. It is a clinical requirement, research requirement. So there are a specific AI who works on the different platform. We want to bring in the open standards. So we want to bring in the open standards. When we say that, it should be seamlessly integrated, available across the workflow within the hospital. That means tightly integrated with your LIS, your HIS, and wherever you want to share the information, connecting with the different peer and discuss all those things, we can do that. Algorithm, the clinical things to the orchestration, how we are moving in that. Multi-vendor AI capability, we don't want that you should take a specific which a company A is supplying it to you. If you are generating your own AI, that also can work with your existing imaging. So that is another thing. And in the future we have is how we should make AI invisible for you. So we can start one by one. If you can see on the base, we have a multiple AI application for pathology, quality, biomarker. But as I highlighted it, they all are working in silos. So what we need is an integration. So we should have a API integration which tightly integrate these AI with the image management system. We have the security, flexible in deployment. We cannot customize each and every AI for a hospital specific and do the integration. And then on top of it comes is a standard layer. So the DICOM, we say FLAIR, we have HLL. So those integration, we have IHE profile. So that standard layer should be there. And end of the day, as the workflow goes in the lab, what we have is LIS, order, digitizing images, tightly integrate with the image or the viewer. Then your AI will run out of it. And we also have something called as AI which can help us even in the reporting. Typically the structural reporting. Your key images will come automatically and sit on your report when you are sharing with the clinicians or with the patients. So this is the direction where we are looking into it. We have also said in the key area where we are focusing that we are moving towards the orchestrator. What does it mean when we say orchestrator? As a clinician, your time should spend much on the clinical activity. You are seeing the images, you are reporting out of it. But the quality of slide, why not AI should do that activity for you? So from the slide preparation, slide is getting arranged, getting it digitized, and when it is ready to report, AI should come across this workflow. So improving your workflow efficiency, improve the diagnostic quality, and then come across the journey where you are spending your time. So this is the how we look the different AI, what Philips bring it for the customers across the portfolio. Now we have also come up with a solution called, the way we have seen in the Google or the App Store, we also have a called marketplace. So we are giving a complete flexibility to the customer that you can choose your own AI which best suits as per your requirement today or for the future. And as has been explained earlier, we have IBAX, Visioform, Eforio. So these all are the vendors which are currently available for us, which is going to help us in the AI-driven reporting. We have also said in the previous slide how we should make AI invisible in your workflow, and that is only possible the utilization and the tightly integration will go. So your regular workflow or the activity will hide up that you have to launch some application which will work and it will consume the time. It will work on the back end. So we have a couple of applications like prefetch. It captures the images. If the same patient image is there from earlier, it consolidated those images, bring it in front of you. Prior, you can sit and start analyzing the images. So it saves a lot of your time and increase the throughput or the efficiency. So few key takeaway when we are winding it up this discussion is AI adoption is now an integration challenge, not a challenge with the algorithm. That has been visible. The open standard, the vendor neutral ecosystem is essential to scale up the AI. Unless and until it not be vendor neutral, half of the work will be integrated, half you have to work it separately on that. And the last but not least is the future integration, that is AI orchestration. That means starting from the slide preparation, the quality of the slide, image, clinical finding, and the reporting. Everything will be tightly integrated. And when we implement this, we have the statistics. It helps us to improve the TAT. And we have the few customers within India and across the world who has implemented the AI. And we have seen how this tightly integration or making them towards the digital pathology department has improved their clinical finding. That's it from my side. Thank you. Any question?
Good afternoon, sir. My name is Aditya. My question is, when you're considering, integrating such orchestrational layers into the field, do you even consider about whether doctors would be happy integrating it? Because at the end of the day, if a doctor is not willing to use it, the whole thing becomes pointless. So have you even considered that? Because tier 1 and tier 2 and 3 also matters. Somebody who's open to implementing or experimenting here in a city might not want to do it in a rural area. So how do you map that in your plans?
Okay, so when we say orchestration, we have multiple things which we factor doing the orchestration. So we have started thinking about the orchestration on the importance of this study.
Audible? Okay. So, thanks to GHA and the organizing committee of this meeting. I really like the title of this program, Health to the Power of AI, meaning that AI is actually empowering health and healthcare. But the topic given to me is what happens if AI gets it wrong. So the moment I got this topic, initially I was like kind of little difficult one. But then when I saw the esteemed panelists, the expert panelists, galaxy of stars who are there to support me here, then my job was made much easier. So we have Professor Ramesh Bilimaga, Professor Jogarao, Professor Alok Dhawan, Dr. Vikram, I think is joining online, and Dr. Shivkumar Swami, Dr. Sumana, and Dr. Shabnam. So they'll make my job easier, I guess. So we are going to cover a little bit on AI in medical field, how AI is shaping up in hematology, oncology, radiology, and pathology. Do we have any guidelines or accreditation for this? What are the pros and cons? And touch into some case scenarios. No disclosures. So what is the first thing that comes to your mind when you think of artificial intelligence? Anybody wants to volunteer? What's the most used AI at present by all of us? Yeah. So the thing which comes to our mind is ChatGPT, right? Nowadays, for anything or everything, probably we just look into ChatGPT to see how it helps. So AI in medical field is fast evolving, and in hematology and oncology practice also, it's transforming healthcare. It's helping in diagnosis, treatment, patient management. In hematology and oncology perspective, it's supporting precision medicine, early cancer detection, and personalized care. In hematology, we already had automated interpretation of CBC and peripheral blood smears. Now we have AI-assisted classification of leukemia and lymphomas, detection of abnormal blood cells, workflow, laboratory workflow, for example, AI-based digital microscopic flow cytoanalysis, bone marrow image analysis. In oncology, you have a lot of early cancer detection from imaging, where you are incorporating digital images along with AI models, AI-assisted pathology, precision oncology, a lot of radiation therapy planning and optimization. So ultimately, the benefits are earlier diagnosis, improved treatment, and improved patient outcomes. So it's beyond debate that there are definitely a lot of benefits of AI, and we have definite advantages in the clinical practice. It is reducing the workload, remote patient monitoring, for example, tele-oncology. It's enhancing clinical research. But we have to take this with a pinch of salt, because there are a little bit of limitations which we are going to touch upon in the next few minutes. Data privacy, cyber security concerns. We don't have any black box AI warning. Regulatory and ethical issues are there. High quality, validated data assets are required. So the bottom line is AI complements, but definitely does not replace the clinical expertise. With that background, let us dwell into a couple of cases and just discuss these points in more detail and hear from the galaxy of stars and the expert panelists which we have here. So we have a 45-year-old lady. She has presented with left breast lump of 1 month duration. There is no family history of breast carcinoma, no other significant history. Mass is about 2 into 1.8 centimeter, one firm, slightly fixed. Nipple areola complex is normal, no palpable axillary lymph nodes. Ultrasound with mammogram done, Birard's 3 or 4A. So my question to Dr. Shivkumar, based on this mammogram finding, what would you suggest to the patient based on this finding and what we are seeing on the mammogram?
Yeah, definitely the mammogram and the corresponding ultrasound image shows a speculated lesion which is highly suspicious of malignancy. It's not just Birard's 4, probably we would put it as Birard 4C, high index of suspicion. It has to be biopsied.
And are these algorithms being developed or used for such interpretations in clinical practice? And
Yes.
what is their accuracy?
I mean, in terms of AI, in detection of cancer, mammograms are the one which has led to significant developments across the globe. So now there are many, vendors that are available, validated, FDA approved. Definitely, their accuracies are quite good. Some of the companies whom I know, the accuracy is as high as 95 to 98%.
So the bottom line is mammogram is abnormal.
Yes,
and
definitely.
the AI interpretation of these algorithms are in use. So this is the FNAC. Based on the mammogram finding, FNAC is done. We are seeing some atypical cells here suspicious of malignancy, and biopsy has been suggested here based on the FNAC smear findings. So my question to Dr. Sumana is, what would you prefer for diagnosis of breast lump, FNAC or biopsy, and why? It may sound very simple question, but I think we need to give this message to the audience here. And based on that, what is your opinion based on these smears, and what would be your recommendation to the clinician?
Yeah, to take up the first question, we always prefer biopsy over FNAC, and because of when the lesions are like a proliferative epithelial lesions, like what is being seen in this FNAC smear, it appears as a proliferative epithelial lesion, and it may not be completely representative. So the differential diagnosis would be ductal hyperplasia, 2 other lesions, and there could be a possibility of low-grade malignancy, which cannot be completely ruled out. So as such, the smears show there is no features of an unequivocal malignancy, what is seen in these pictures, the FNAC microphotographs, what we saw just now. So the biopsy is necessary to avoid a misdiagnosis. And as we all have heard through these sessions today, we would be able to apply the breast biomarkers, the ancillary diagnostic testing on it, and this is important for the patient care. So the recommendation to the clinician would be to go ahead with the needle core biopsy.
The bottom line is better to go for the biopsy, and FNAC alone may not help. So that will be your recommendation. So rightly so, patient has had a true cut biopsy, but pathologist is in dilemma, not sure if it is benign or malignant. Unfortunately, it was not discussed with the clinician or radiologist. Used AI model on cloud. AI called it as invasive ductal carcinoma, grade 2. Pathologist signed it out as invasive ductal carcinoma, grade 2. So again to madam, what's your impression of this biopsy, and would you consider any differentials? I'm sure you would consider doing an IHC on this case, or what's your opinion based on the biopsy?
This biopsy, if we can have the picture again, so some pathologist audience can be seeing. There is the ductal proliferation. One of this acinar pattern is seen with the peripheral myoepithelial cells, what is obvious in the one at the center. Others, we are seeing attenuated ducts, and so there is a, that it could be a benign lesion. It looks a lobulocentric proliferation, but the lobular connective tissue is replaced by the dense fibrous connective tissue here, and so we'll have a differential diagnosis of proliferative epithelial lesion, including the ductal hyperplasia, a possibility of a sclerosing adenosis. All these have to be kept in mind, and definitely we have to take into consideration the mammogram reports also. And as sir suggested, this mammogram is suggestive not only of a 4A, it could be 4C. There is a suspicion of malignancy. So we need to go with the biomarkers and the ancillary testing, including immunohistochemistry for the to look out for the myoepithelial cells. As such, in one of the ducts, it is obvious, but because it may be multiple lesion may be represented also, so we need to discuss with the triple approach is very important. Discussion with the clinician and considering the radiological features and go ahead with the biomarkers is very important.
So detailed discussion, tumor board, multidisciplinary, and detailed evaluation of the pathology should have been done here. My question to Dr. Alok Dhawan and if Dr. Vikram is online, what is the best AI model in this kind of situation, and how accurate are these models launched on cloud, and how accurate are the open source models, sir?
So I think it'll be difficult for me to say which ones are best on the cloud. Depends on how well they are validated, especially when you talk of open source models. I think it's good to test out these models in your facility in the hospital if you're going to deploy them. And once you're 100% sure that they give you good results, I think Dr. Rajen Singh mentioned in the morning, I think it's fantastic to use them as a tool once you are convinced that these models are giving you accurate results. But I think by and large, the good models give you accuracy of almost 95% or so. So I think it's a good idea to deploy them. I think let Dr. Vikram talk, and then perhaps we can go on to the regulatory part of it.
Yeah. Dr. Vikram, is he there online? Okay, sir, he's not there. We can just, so your message is that the AI models which are validated are probably okay to use.
Yeah, so we were using machine learning tools that were openly available a long time ago. But I think the more you get validated, those tools are validated, I think that's how you get confidence in these tools. And we're dealing with humans especially, so I think we need to be even more careful when we use them.
And are there any regulatory guidelines in India on the use of AI
So
applications?
I'll come to that
in
if you
clinical-
permit me, since Dr. Vikram is not there and we're talking of accuracy in the models.
Sure, sir, sure.
I think one should understand, and I was talking to some, I think one of the guys from Philips, data is the mother of all this AI that we're talking about, right? Human intelligence is what is driving AI. So we should not forget that how the data is collected right from when the patient walks in and you're typing in the EHR. I think that is where it starts. And all the way up to the end where you have pathology or other diagnosis done, I think every step should be analyzed for its accuracy. Only then the AI model will be good. Secondly, I think it is important that for those who are into active research and upload manuscripts, I think I was just getting this idea sitting behind that when you upload a manuscript, there are portals now who ask you every single thing to be copy pasted. So you paste your names first and then you paste your title or title and then names and the abstract individually, and then finally the manuscript automatically assembles. So I would be of the opinion that when, let's say from a primary care hospital, the patient is getting transferred or getting referred to the tertiary care hospital, I think that is where it should all start. All the history information should be in a format either on a blockchain or where it cannot be mutilated while it is getting transferred. So right from the history onwards, all the way up to a pathologist report, I think that gets captured. Regarding the guidelines, I think CDSCO has guidance for this as well as ICMR on the ethics issue. So I think these are all available online and one can go through them in terms of guidelines.
Thank you, sir. You covered most of the things. There is CDSCO, where Software as a Medical Device Rules Act, and then you have ICMR, Ethical Guidelines for Application of AI. It's very much there in 2023, and those are the key principles. And like you mentioned, clinical validation is a must, analytical validation, technical performance in intended patient population, and external validation across multiple hospitals has to be done before put into clinical practice. And most of the hospitals will have ethics committee, IRB, approval for research use, IT and cybersecurity, data privacy, defined clinician oversight. So all this is a must before putting it into clinical practice. Now, this case, what happened subsequently, this lady underwent left breast radical mastectomy, histopath exam, that's what it is showing. I'll take help of Dr. Sumana on that. But the final diagnosis was given as sclerosing adenosis, no DCIS or malignancy. So, I mean, with due respect, I know Professor Ramesh sir is not a surgeon, but how justified is mastectomy for a 2-centimeter lesion? And no hormone receptor testing done also. What's your comment, sir, on this?
It is first of all, even before you embark into asking this question, forget about AI for a while. What you would have done, even when the case comes to us, in the beginning itself, we would have consulted the radiologist, we would have consulted your colleagues and undertaken steps. So therefore, do not bring the AI in the first field. Even if AI says malignancy, you are not going to act, you should not act. So therefore, the question is the clinicians the first has to be done. In this case, going by this and doing a mastectomy in these days, it's really really not good act at all. Not at all.
Agreed, sir. This case was not managed at our center.
No, it doesn't matter which center. So let's not discuss about any other center.
I totally agree with you.
Yes, the point is you are a clinician. Forget about it. A comes later.
Yes.
So if the clinician is not agreeing with that, A is not going to assist. But you can ask a question, in this situation, what will be your probable diagnosis? That gives you, if it is concording with you, yes, you keep that in mind. If it is not, then you let me very closely go in close observation.
Agree with your point, sir. Where definitely this case should not have been managed like this. And now since this has happened, my question to Professor Joga Rao is, say this has happened. And what is the role of ethics and law in clinical use of AI models for diagnosis?
Just what Dr. Ramesh said, I just want to make a reference. To me, clinician has the paramount role AI is only to be construed as a clinical decision support tool. That's it. It does not substitute the clinician.
Absolutely, sir.
If that is the case, 2023 ICMR document very comprehensively deals with, no doubt there are several areas needs to be improved. Universally, there are 4 ethical principles which to my mind, they guide the AI in healthcare. Unlike other industries, other situations, healthcare is completely different. The first one is beneficence. I mean, the overall outcome of AI is to reduce human error and enhance the positive outcome for the patient.
Absolutely.
Second, non-malfeasance, which means any harm which is potential that is to be avoided. And autonomy, I think this is something in terms of individual informed consent and situation like counseling is very, very crucial. And finally, transparency and fairness. I think those are the 2 aspects. They reiterate the validation which Dr. was talking about. These are the basic ethical principles.
Absolutely, sir. Point well taken. Since this has been covered, Dr. Alok, would you like to comment anything further, or this has been covered, the second question?
So the first part, I think I'll just make a point that you can definitely talk to hospitals and sell your algorithms if you're solving an issue. But end of the day, like Dr. Jogarao said, it is the responsibility of that hospital or that facility who's using AI to ensure that it is providing correct results and validate them properly. So I think that is where I'll stop.
Okay, I think this
I
Ramesh
just
sir
would
has
like
already
to
covered.
add one sentence.
Yes, sir. Sure.
Whether algorithm requires any kind of clearance, it depends upon the intended purpose of the algorithm. For instance, algorithm to enhance knowledge, send health alerts, etc., we don't require. But so far it gets into the field of diagnostics. Naturally, software as medical device, coming under Medical Device Act and Rules 2017, we need to follow.
This has been covered. How should a pathologist or radiologist protect themselves when they use such AI models? I think both you, Jogarao sir, Ramesh sir, and Alok sir have highlighted that AI is going to complement the clinical expertise, and only when it is validated and proper protocol has to be followed before it is implemented. But anything else, sir? What precautions to take? Would you like to comment?
No.
To tell you how the algorithm is really developed, what purpose and who and where. So whether that is suitable to our situation, that has to be assessed first. Okay, and even in your hospital, if the hospital authority has given to use of AI, and how frequently and that's being audited, and the actual usage of AI even in the system, how well is it dependable on has to be validated in your hospital itself. If you don't do that and jump onto that, and you will get into a problem.
Absolutely, sir. Point well taken. The model has to be validated. We have to find out what is the accreditation for that as per the guidelines, and then the hospital IRB or ethics committee. Before that, we should not put into practice. Madam, you had a comment? Anything, ma'am?
The responsibility finally lies on the pathologist, because unless the pathologist vouches it is a malignancy or it is a benign, the surgeon would not go ahead the procedure. So the pathologist has to be very cautious, and it is very important that the data is important here, how we train the AI model. So the data and then verification, even after the AI gives its report, it is a pathologist who signs out, and so definitely the pathologist has to review the slides and then sign it out.
Just one second. To my mind, the role of pathologist ought to clinical correlation. What's fundamental? Secondly, the very outcome of AI assistance is not to create a pathologist-free pathology.
Fantastic point, sir.
It has to be a pathologist centered around AI. That's where decision support.
So pathologist should be complemented. I mean, the AI should complement the pathologist so that the pathologist becomes a super pathologist, something like that, rather than competing. So let us say if this kind of a situation happens, sir, especially Professor Jogarao, sir, let us say this kind of situation has happened and there is a liability, then who is liable in this situation? Surgeon, clinician, pathologist, or the AI company? Quickly, if you can comment on that, sir.
In my opinion, all the three are liable depending upon the facts and interpretation. The only one is AI as such is not liable because it doesn't have a legal personality status in India. But otherwise, the company which developed, the pathologist who invoked, and the surgeon or clinician who used that particular thing can be subjected to.
Fantastic.
Where exactly, what is the ground? Pathologist, for example, blind acceptance of AI report, I think that's the major issue. Clinician not having considered the kind of thing. For example, in the context of cancer, multidisciplinary discussion, I think plays very important.
Absolutely, sir. Ramesh, sir.
Yeah, going further, if you put a hierarchical system here, final no buck stops at the clinician, okay, and the AI company and with their vendor and what kind of a contract that you have. Today we should have a contract, and which is vendor is also responsible, and in both in terms of insurance and in terms of maintenance, he is also responsible. So your contract has to modify that in that AI. Okay, so that's how we can really chip them also into this. And come to pathologists, unless they are very sure that this is a malignancy and not malignancy, it's fine. But when they are in doubt, and obviously the ball lies on the clinician, what he wants to take. So what I want to say is ultimate buck stops at a clinician, and he is the one for first contact with the patient.
Sir, point well taken. Dr. Shivkumar, you have a comment?
Yeah, I think the thing is, when we are trying to implement such a model, AI model for a clinical use, unless that model is approved, has got all the approvals, whether it's FDA and it has been tested across the population, no institutions should implement such a model, whether you're trying to test or anything. But ultimately, it's the clinician and the radiologist or the pathologist who has to take the onus. This is something which has to be discussed at the management level also, whether we are going to use such a system. Having said that, because of the volumes, huge volumes of diagnostic services, it's always possible that the hospital will ask you to use the AI. This is very commonly done across the globe, where more and more chest radiographs are not reported by the radiologists. One, it could be because the huge volumes. That fatigue factor is also there. Even if with the best of the radiologists, he may be able to read about 80 to 100 radiographs in a day, but whereas an AI algorithm can go, there's no fatigue factor for that. But if you bring in such an algorithm, it is still the radiologist who is responsible. So in the end, a proper approvals has to be there before we use such a model.
Very valid point, and you gave the example of X-rays there. So what could have been done in this case? Already highlighted.
If I can just chip in here. I think when you talk about liability, I think it is a dynamic system as of today. So we would not have fathomed the fact that AI humans are sitting discussing artificial intelligence in hospitals. But I think as we move along, as we get more confident, that's how we are going to set liabilities in place. As of now, we are saying pathologist is liable, or clinician is liable, or AI is liable. When we use softwares or use transactions for money, the person who has actually built that software for transaction of money is liable. So AI at some point in time could be liable because that's how they trained the model. So I think it's a dynamic field, so are the guidelines and the policies as well.
Point well taken, sir. So this has been discussed. We should have had a MDT discussion, clinico-radiological pathological meeting, careful usage. Quickly move on to the second case. 7-year-old boy presents with history of fever, fatigue, weight loss, 1 week duration, no other significant history. Child is pale, he is having bilateral cervical lymph nodes, more on the right side. And there is a mild hepatomegaly. CBC has been advised. Fever profile, workup for the fever has been done, that is negative. And this is how the CBC looks. Hemoglobin is 9. There is leukocytosis, 20,000 WBCs. Platelets are slightly low, 70,000. Differential is interpreted by AI. Neutrophils are 20, lymphocytes are 50. There are some atypical lymphocytes, 12% and 8% of blasts. So the AI report generated is atypical cells, query blast, suspected acute leukemia. Pathologist has reviewed this and he or she, they feel that this is reactive lymphocytosis and this could be post-viral. So over to Dr. Shabnam. We have cell counters which are providing differential. It's been there for quite some time now. How is an AI model different from the cell counter? And is the pathologist justified in signing out this diagnosis based on the smears that you saw?
I'll answer the first question by giving a small comparison. So cell counters have been there for a long time, yes. They are using a basic traditional AI where they use machine learning and some internal algorithms to identify the cells, count the cells and classify them. They will give you cell counts like hemoglobin, MCV or cell counts, and they also give some flags. It could be platelet clump flag or a blast flag. They will give you the results, not what those results mean. That is what the traditional cell counters do. Whereas the digital morphology, where what you're seeing here pictures, they use deep learning to have a very common, sophisticated algorithm and pattern recognition software where they recognize the cells and classify them as where maybe blasts or whatever. So they recognize the cells. They don't give the diagnosis. They like this. Here you can see that suspect acute leukemia. They give you a suspicion of what they are seeing. Whereas the generative AI, it does neither deep learning nor machine learning, but it is capable of producing new content. So it takes the inputs from the CBC, it takes the input from the digital morphology, it takes the input from the clinical history, and it gives you the interpretation, differential diagnosis, and also it gives you what next steps to be done. So put it in a single sentence, cell counters give you the count. The digital morphology recognize those cells. And the AI or the generative AI will explain what it is seeing. So this is in brief. And to come to the next question, that is the pathologist justified? So if you see, go back to the clinical history, the points in favor of the reactive lymphocytosis, I'm assuming the pathologist here means that it is infectious mononucleosis, not dengue or anything else. So here the points in favor are the fever of 1 week duration. Then there is a mild bilateral lymphadenopathy and mild hepatosplenomegaly, and the fever panel. Sometimes infectious mononucleosis is not part of the fever panels. So these 4 points are in favor of this diagnosis. But what is against is the weight loss, the anemia, the fatigue, and then coming to the morphology. These kind of cells are not typical of a viral infection. In viral infection, especially infectious mononucleosis, you will see abundant cytoplasm with peripheral inking and skirting of the cytoplasmic borders, which is not seen here. So since it is not a classical morphology of either a blast or a reactive cell, I wouldn't give a direct query viral post-viral infection. I would give a differential diagnosis and suggest for further testing to confirm the diagnosis. So that would be a justifiable diagnosis.
Fine. So you would not sign out based on this, and you would want a further workup for this child.
Yes.
Maybe depending on the clinician, based on the multidisciplinary team, if they decide to do a marrow or something.
Yeah.
So, sir, is development models for hematopathology different from that of histopathology? Dr. Vikram is not there. Alok, sir, would you like to take that, or is it you? Development models for hematopathology, is it different from that of histopathology, sir? You have any comments on that, or we just?
So I think histopathology would also include the tissue architecture, etc. I think that becomes a bit more complicated as opposed to the hematopathology. Secondly, I think when you talk of histopathology, the tissue architecture of different tissues would be different. In different disease conditions will be different. At different age groups might be different as well, depending on the tissue. So I think from that perspective, you need to be a bit more rigorous or a bit more careful when you design these models and develop them. I would say development may be a bit difficult, but validation would be even more difficult after that.
So 2 weeks later, this child comes back to ER with high fever, with chills, increased nodes, hepatosplenomegaly, hemoglobin has gone down further, WBC count has increased further, platelets have gone down. This time the AI has interpreted as again 30% atypical lymph blasts, acute lymphoblastic leukemia, pathologist reviews ALL, bone marrow is done, flow cytometry confirms diagnosis of ALL with 61% blasts. So here what has happened is AI told on the initial CVC that there is a suspicion, but then when the pathologist reviewed, it looked like it could be post-viral, short history based on the clinical correlation, and then the child has come back later with a diagnosis of ALL. So, like we were just discussing on this line, sir, there are so many startups in work. Madam, your comment on the case?
Yeah, if you compare the morphology here, this is a very typical morphology of the blasts, lymphoblasts, whereas the previous image which showed, it was not so classical. So the pathologist was right in not calling it acute leukemia, but then still I think she should have given a differential rather than directly calling it as a viral infection.
And multidisciplinary team meeting is a must. Had this case been discussed in detail, then maybe at that point of time more workup would have been done. Sir, if such a kind of thing happens again, Professor Jogarao sir, you covered this in the previous case. So such a thing has happened here. Now the family may come and ask us that since the AI had given a diagnosis of query leukemia, but at that point of time, clinician did not go ahead and do further, and now 2 weeks later, child has come with full-blown leukemia now. So if there is a liability in this kind of situation, who is liable here?
Naturally, the pathologist. The legal issue before the court would be whether the standard of care, what the pathologist has undertaken, it could have been much more meticulously excluding leukemia, what he could have done. I think that's the test.
And in addition, the clinician also becomes responsible, sir,
Yes,
because
yes,
ultimately
definitely.
the clinician is also
Sure.
involved in the care and he has taken.
You go ahead. There is a very important, doctor would agree, there is a test called flow cytometry. So that should, I mean, before you get in, because the perception you're giving is, it's not a very well worked up hematopathology case. You need to do a flow cytometry and be very sure and then go, because it's morphological quantification, any pathologist will agree, is not definite, neither is AI. So there are certain steps that need to be done, and then you get into calling it something. Similarly, for the first case, the tissue morphology, and as ma'am said, the background, everything, this is the pathologist who finally makes the call, and whatever AI model you do, the conversation with the radiologist, the clinician, and a pathologist, which any pathologist over decades would be doing, is what gets you to a final thing before getting anything done.
Sir, point valid.
Totally.
We are not here to put any blame on AI.
No, I'm
Neither
not.
are we to say.
No, I'm not
Sir,
blaming.
Let me answer your question.
I'm not blaming. I'm just setting the record right, because I've been doing this for 25
Sir,
years.
we have just chosen these two case scenarios to show that in the first case, the AI predicted the diagnosis of malignancy initially, but the final pathology was something else. In the second case, AI has predicted that it may be a blast, but because the pathologist felt it was atypical lymphocytes, with atypical lymphocytes, pathologists will not run a flow cytometry. Once he or she feels that it is a blast, then they will run a flow cytometry. No, that's what she commented, no, sir?
Yeah, I agree with you. If you have a doubt, we have
When we are in doubt, we'll run it, sir.
And we have so many modalities now available to us. Maybe 20 years ago, we did not have those further tests available. Since we have that and they're readily available, why not use those test modalities and be
Absolutely. Just wait for me to summarize the case, sir. I will definitely add on to that point. That's what we are trying to emphasize here. See, here in this case, there was clearly a discrepancy in the report. And what is the learning from this case? For sure, this case should have been discussed in detail. And if there was an element of doubt between the AI as well as the pathologist, better tests like flow cytometry should have been done upfront, or like on the biopsy, bone marrow biopsy, if you're not seeing, IHC should have been done upfront. That is what we are trying to see from this case. So with that, So these are the future perspectives. I think AI is here to stay in hematology oncology, and it's going to complement the clinician's perspective. And we have to be a little bit careful with choosing the AI models based on the accreditation, validation, and the local institution research. And I think in future, this is what we are doing in our tumor board and MDT, where at every step, pre-diagnosis to diagnosis, precision medicine, personalized treatment planning, and like for example in leukemia, we have MRD assessment to look for molecular basis of whether any residual disease is there or not. So AI is definitely revolutionizing, and it's the most effective approach, and it is here to stay in pathology, in radiology, and we all know that AI complements and it's not going to replace the clinical expertise. Thank you. If there are any questions, we'll be happy to take.
Thank you, sir, for this session. This has taught us that AI will definitely help us make better decisions.